Hi, welcome back to the Americans with Disabilities Act State of the Science virtual conference. We're so pleased to have you here. I'm Kurt Johnson, and I co-direct the the ADA Knowledge Translation Center, which is one of 11 centers that make up the ADA National Network. I'm speaking on behalf of Dr. Mark Harness, my colleague, who has an internet connection that's not stable enough to allow him to assume this role today. Many of you know of the National ADA Network, but for those who don't, it includes 10 regional centers, and you can see those on a map that's coming up, and our ADA National Knowledge Translation Center. The regional centers provide information and guidance about the ADA to anyone in the United States through a toll-free number and through email. They also provide training to businesses, nonprofits, state agencies, and other organizations on request. The ADA Knowledge Translation Center supports the national efforts of the regional centers by coordinating the development of information materials and initiatives, including the national website and social media. The network is celebrating its 30th anniversary this year. Next slide. The ADA National Network is funded by the National Institute on Disability and Independent Living and Rehabilitation Research within the Administration on Community Living. We'd like to acknowledge and thank our funder for their support of our work and of this conference. Now, many of you have used Zoom in the past, but here are just a few things about the Zoom webinar. You should see slides on the left and the presenter and ASL interpreter on the right. You can use your mouse to click and adjust the size of the video in PowerPoint. We'll use chat and Q&A, and I'll explain that in a minute. And the audio settings are on the left bottom of your screen with advanced view options on the top middle of your screen. Now let's talk about audio. Next slide. The audio for today's webinar is being broadcast through your computer. Make sure your speakers are turned on and your headphones are plugged in. You can verify the audio settings. I'm sorry, Mark's chat note just covered up the slide. The audio settings option in the lower corner of your screen, and you can adjust your volume using the audio settings option. Next slide. If you have trouble with the computer audio, you can switch to the phone. Select the audio settings, choose switch to phone, and follow directions to dial the number and log into the webinar when personal ID number. You'll have an opportunity to ask questions. All questions should be submitted via the Q&A. You'll have the option to submit your question anonymously. Do not submit questions in chat. We won't be monitoring it for questions. If you're listening on the phone and are not connected to the webinar platform, email your questions to adakt@uw.edu. Upvoting questions. If you see a question you like, you can upvote it by clicking the thumbs up icon. Upvoted questions will rise to the top and be more likely to be asked. If you have any technical difficulties during the webinar, send a message in the chat area or email us at adakt@uw.edu. Real-time captioning, or CART, is provided by both Zoom and StreamText. The StreamText link will be posted in chat. If you're using the StreamText, you'll open a separate browser to view the captioning, and you can resize your screen so that you're able to view both the StreamText and the Zoom platform side by side if using a desktop computer. Zoom offers the option to mouse over and move the captioning box anywhere on the screen to customize your view. Within Zoom, you can choose to view the full transcript by mousing over the CC, quote, live transcript icon and selecting full view transcript option. The ASL interpreters video will be spotlighted, so they always show on the top of the screen. There will be 2 ASL interpreters, and they'll take turns during the session. There may be a brief pause as they transition. And please note that tablet and phone options for viewing the video will differ depending on the device. To ensure equivalent visual access, presenters will describe any visual content on their slides. In addition, presenters may provide a visual description of themselves. So for example, I might say, my name's Kurt Johnson. I'm a white man approaching 70 years old with long red hair that's tied back so it looks more presentable. I'm wearing a shirt, and this is an increasingly common practice today in disability studies circles, but it may be new to some of you. So now let's move on to the keynote. Today's theme is access and inclusion. First, we'll hear from today's keynote speaker, Michelle Bishop, with the National Disability Rights Network. Michelle will present for about 30 minutes, and then we'll have some time for questions. After that, we'll have a short break and then begin 5 research presentations covering a variety of topics related to access and inclusion. We won't take questions during the presentations, but we'll have 20 minutes after the last research presentation. Following the opportunity to ask questions, we'll take another short break. And after the break, we'll have our closing speaker, Mary Lou Breslin, who will summarize what we've heard today and where to go from here. So with that, I'd like to welcome Michelle Bishop and take it away.
Hi, everyone. Good morning, and thank you so much for having me. It is absolutely my honor to be here with you today. As you heard, my name is Michelle Bishop, and I am the Voter Access and Engagement Manager at an organization called the National Disability Rights Network, or NDRN. If you don't know us, I bet you know our network. We are the National Membership Association for the Disability Rights Network, or the protection and advocacy agencies. And I would be willing to bet that you know yours. I was asked to join you today to talk about our theme for today, access and inclusion. And initially, well, if you know me and you know my work, access and inclusion is the heart of what I do, but in a limited way. And I'll be honest, I really asked myself, am I the right person for this? When I think about access, that to me means access to the ballot. When I think about inclusion, that to me means inclusion in elections. And access and inclusion realistically are so much bigger and so much broader than all of that. But when I thought about it, sat down and really thought about it, I thought there is no way to talk today in April of 2021 about access and inclusion and not talk about the year that was 2020 and everything that we experienced and everything that I believe it taught us about where we are with access and inclusion and where we go next. And that's what I'm gonna talk to you about today. To give you just a quick description, I am a white woman with usually unruly curly brown hair that's being especially cooperative today, for which I am thankful. I have a big plastic frame, black glasses, and a black sweater on, and I am sitting in front of what I believe is now my internet famous dining room wall. I have a lime green accent wall in my dining room, and because we've been working from home so long, this is how all of you see me now. But with that said, let's dive into it. Let's go to the next slide. So you could say that 2020 had it all. It really did. It had it all in probably the worst way possible, but 2020 did truly have a little something for everyone. If you remember going all the way back to the start of the year, we kicked this all off with wildfires. If you remember when all of Australia seemed to be on fire, that was January of 2020. I can remember how hopeful I was on New Year's Eve, and I'm not even a New Year's person. And then I remember 2020 coming in with a bang. And so right from the start, we started at least our work, and I bet a lot of yours, with questions about are we prepared to evacuate people with disabilities in the case of natural disasters? Our work started right away in January 2020. We went straight into a period of intense but necessary civil unrest in the face of racial injustice and police brutality that was made 2020 an even more important, if difficult, year. And I'm so thankful for so many of my colleagues who are out there leading the Black Disabled Lives Matter movement and the important work that they did in 2020 and everything that they taught me in 2020 about intersectionality and the ways in which we are all truly connected, in the way in which all of our fates are linked. And I suppose that was truly driven home by the headline of 2020. Of course, we found ourselves unexpectedly in the worst pandemic we've seen globally in 100 years. You can't talk about 2020 and not talk about the COVID-19 pandemic. So much of what I'm going to talk to you about today is, of course, driven by everything that we did in response to the pandemic to get through 2020 to where we are now. But all of that culminated in late 2020 with a presidential election. And this was just not your average presidential election. This was a presidential election in which we were expecting historic levels of turnout. In going all the way back to fall of 2019, about 2/3 of Americans were saying they were more excited for this election than they had been for any recent election. Those numbers, if you think about what voter turnout rates look typically, those numbers are exceedingly high. All the way into summer, early fall of 2020, about 7 in 10 Americans were saying in public polls, Gallup polls, that they were thinking a lot. They had given this election a lot of thought and were ready to go and vote. Those numbers are exceedingly high. We don't get those numbers in every presidential election. And so all of a sudden, we found ourselves in a place where we were going to have to figure out how to process a historic number of voters while keeping them all 6 feet apart. Running elections is hard enough. Making elections accessible, I promise you, is even harder. Doing it when we have to keep everyone 6 feet apart was a truly unique challenge. Now, I'll say voters delivered. We indeed got historic turnout. One candidate got the most votes a United States presidential candidate has ever gotten in a presidential election. The other candidate got the second most votes a United States presidential candidate has ever gotten in one of our elections. You all really made it to the ballot box and you showed you were serious when you said you were thinking about and excited about this election, which is amazing. All credit to you, but it came with its challenges. And we're going to talk about that. We're going to get to the election. But first, let's go to the next slide and we're going to back it all the way up. And we're going to talk about all the other ways that the ADA was tested, all of the other ways that access and inclusion were tested in 2020. And I know, given the broad range of topics being covered at this summit, that you all have been talking about this. You've seen the data, you're talking about the data this week, and you know from where we came. But to touch on it quickly, I will say, you can see here a real ABC News article that said COVID-19 pandemic reversed decades of employment gains for the disabled, but advocates see glimmers of hope. I am so glad that in 2020, some of you saw glimmers of hope. I did not. But this is real. This happened when the pandemic hit. More than half of workers with disabilities polled said that they had either lost their jobs, been laid off, or furloughed, or believed that they were going to lose their job within the next 3 months, as compared to just over a quarter of people who don't have disabilities. In 30 years of the ADA, we've made so much progress. But when times got hard, when it really mattered, it became clear how much people with disabilities are still the last to be hired and the first to be fired. How disposable so many of our jobs truly are when our economy really gets tough. Just a wake-up call that I don't know about you, but I was not prepared for. You'll see also here, I included this quote for you that I saw in 2020 that hit me so hard. A person named Stuart Sherman, who at the time was the executive director of the New York State Task Force on Life and the Law, who said, "Are we comfortable sacrificing this group in exchange for saving more lives?" There's no way to talk about people with disabilities in 2020 without talking about rationing of care. We have come so far in terms of civil and human rights for people with disabilities. But as soon as our healthcare systems were tested, as soon as our hospitals got overwhelmed, our medical professionals and our state and country leaders started asking, whose lives are worth living? Whose lives are worth saving? When we have limited resources to go around, are we going to save people with disabilities? People most at risk for complications from COVID-19. And in so many ways, even before we hit those emergency room capacities, what happens to people with disabilities who rely on a respirator in their everyday lives when respirators become a preferred treatment for a disease and we have a shortage of them in the United States? What happens to people with lupus? What happens to people who experience chronic pain when the prescriptions that they have used for years to ensure that they're able to work and live and play in their communities become experimental drugs for all of us to fight a new disease? And suddenly, those medications are nowhere to be found for people who need them for their lives and for their livelihoods. The ADA in 2020 was tested in ways that I don't think we had seen in the last 30 years. And that's what matters, right? When the rubber hits the road, are people with disabilities truly equal? Are we truly included? And I don't know about you, but I spent a lot of 2020 asking myself those questions, especially every time I turned on the news or opened a paper, which admittedly was less and less as the year dragged on for my own mental health. Every time I was confronted with one of these stories and really had to grapple with that question. But that's not my area of expertise. And you've had other people come to talk to you about employment and those issues. Let's go to the next slide and we'll focus in on the thing I really know about, that I'm here to tell you about. Access to the ballot was also challenged in 2020. We saw huge challenges to how all of us were going to be able to vote, let alone people with disabilities who already experience more barriers than the average voter. Going once again all the way back to the beginning of the year that was 2020, right in the center of the screen here, you see this screenshot of a report called Blocking the Ballot Box. This was an Ndrn issued report. This is my organization released this report in January of 2020, because at the time we thought one of the major issues in this election was going to be in-person voting and the ways in which the ADA is actually abused to keep voters away from the ballot box. The way the ADA has been misused as a smokescreen for voter suppression. If you're not familiar with this issue, Google Randolph County, Georgia. There are jurisdictions in the United States that close up to 80% of their polling places in the jurisdiction, and they say it's because, I'm going to say this with finger quotes, they were not ADA compliant, so we had to close them. If you're thinking, what disability advocates are out there and asking for polling places to be closed? I promise you, none of them. These are jurisdictions who didn't have evidence, who didn't provide surveys that showed that these polling places were inaccessible. These are jurisdictions that didn't speak to any of us, didn't talk to voters with disabilities or disability rights organizations when they closed jurisdictions suspiciously where the majority of voters were Black or brown people. This was the issue we thought was going to be at the top of mind in 2020. Well, in January of 2020, we thought that. 2 months later, we were in the midst of a pandemic where primary elections for the presidential election were being postponed for months at a time. They were being converted to fully vote by mail elections. And we saw the challenges early on. In April of 2020, there was a movement in Wisconsin to delay the primary or to increase use of vote by mail. Those efforts were blocked, and Wisconsin went forward with a primary that was mostly in-person voting and intended to be run like a typical election in Wisconsin. In Milwaukee alone, I'm going to say, it's off the top of my head, should have looked it up today. In Milwaukee alone, I think there's about typically 180 polling places. In April 2020, Milwaukee had five polling places, down from roughly 200. There were locations that could not or would not serve as a polling place, some of them for very good reason. A common polling place is actually nursing homes. They're fantastically accessible, and all the residents can vote by going to the lobby. They couldn't serve in 2020. They couldn't get enough poll workers either. They actually used the National Guard as poll workers because they couldn't recruit enough. And poll workers who did work in that election had to bring their own PPE. There were poll workers in Wisconsin in April of 2020 who had made their own masks to work that day. If you remember the PPE shortage we were in at that time, it was horrifying. We saw this throughout the rest of 2020 all over the country. Access was challenged. We lost so many polling places. We thought we were going to be battling this limited issue, and instead we saw a major reduction in polling places all over the country. We did not have enough PPE initially to ensure that we were going to be able to keep voting safe. I spent most of the year worried that we started with such high enthusiasm for this election, but if we couldn't promise people they were going to be safe, like the poll worker you see here that's got a mask and gloves handing you that I voted sticker, that voters were going to sit this one out. We saw challenges to innovations that I thought were fantastic. You can see a voter here with a mask on using a drop box to drop off a ballot. I love the idea of drop boxes, that you can request your ballot ahead of time and there's somewhere you can just go and drop it in a secured box and you don't have to wait in that line. I know that voter. The line that day was 4 hours long and that voter was in and out in 10 minutes because of drop boxes. But we saw challenges to their use across the country, to the point that in Texas, they were only allowed to have one drop box per county. If you can imagine how many people live in some counties in Texas, or even just how physically large, some counties in Texas are bigger than whole states. The challenge it would be to voters to get to those drop boxes, so limited in use, especially voters with disabilities in areas of the country where there is not adequate transportation, especially accessible transportation. We saw states and counties that were interested in using curbside voting. Curbside voting is a fabulous accommodation for voters in any given election. If your polling places are not yet fully accessible, curbside voting can help. Curbside voting is important for any voter for whom getting in and out of the car, standing for any length of time, or walking any distance is a challenge. You can pull up to the polling place and vote from your car. In 2020, in my mind, the smartest jurisdictions leveraged curbside voting because we have voters who are immunocompromised, who needed to limit their exposure, many of whom requested an absentee ballot that didn't arrive on time because we weren't prepared for 10 times more absentee ballot requests than we usually see in an election. I promise you, I personally spoke to voters who tested positive for COVID-19 after the deadline to request a vote by mail ballot had already passed. And we're faced with the choice of either not getting to cast their ballots or having to risk exposing others. Jurisdictions that were prepared to let those people stay in their vehicles and send out a limited number of poll workers in full PPE really did a service to their communities in helping to stop the spread. But we saw challenges to curbside voting. You can see here a case in Alabama went all the way to the United States Supreme Court, People First v. Merrill, and we did not win in Alabama, but we won in many places. And the fight continues in Alabama. We saw real efforts to restrict that. I can't say enough about the huge fight over vote by mail and remote voting in 2020. Vote by mail became the star of 2020 election because of the pandemic. We had problems with ballots that didn't arrive in time, as I mentioned, but there were also real battles over what you would be required to do to receive your ballot. How many witnesses are going to have to sign it? Do you have to get it notarized? Where would you even do that during massive shutdowns in a pandemic? And of course, you see here a great piece from Time that absentee ballot applications are not accessible to voters with disabilities in 43 states. For once, there was a spotlight on the fact that vote by mail systems, how you apply for them and how you receive and mark that ballot, are not accessible to people with disabilities, because traditionally it's all done through mailed pieces of paper that we know for a fact some people cannot read, cannot mark, cannot physically handle. And we suddenly were forced to rely heavily on a method of voting that we had failed for decades, I'll even say hundreds of years, to make fully accessible to people with disabilities. One last issue that I think I really want to bring up around this election, because it's one that was personally so important to me, voters in long-term care facilities. Typically, well, I will say I always worry about access for voters in long-term care facilities, but typically elections officials send staff in to these locations so that people who live in long-term care facilities who are eligible are able to cast their ballots that way. Or they're able to have a family member assist them to complete the ballot or return the ballot for them. Long-term care facilities in 2020 weren't allowing folks in for very good reason, right? To protect the staff, to protect the residents. But all of a sudden, these honor systems we had relied on to ensure that people in long-term care facilities have access to the ballot disappeared. What were we going to do to make sure that those voters were able to vote? This was something we had to fight for. We fought hard for CMS guidance that said that staff in these facilities have a very real obligation to assist eligible voters and make sure that their right to vote is respected. It was a tough year. It was an anxious year. It was all against the backdrop of this terrible pandemic and not knowing what the future is, the same way you feel in a pandemic, but also the same way you feel in a major presidential election. And we had to fight really hard for access to the vote. At this point in my talk, I imagine a lot of this sounds like a big bummer. I can't blame you if you feel that way and you're thinking, why are we starting our morning off with this? Well, 2020 was a bummer, so here we are. But this talk today, this is not the story of everything that was hard about 2020. This is not the story of everything that was awful about 2020. You were there. You already know. This is actually the story of everything that went right in 2020. This is the story of all the ways that we persevered in 2020 and where we go from here. Let's go to the next slide. So we did persevere in a big way. We fought hard. We fought hard for use of curbside voting. We may have lost in Alabama, but we got it established in many other places that were prepared to assist voters. We did remove many restrictions from voting by mail. We saw requirements for witness signatures and notaries waived for voters, deadlines for requesting or returning your ballot pushed back. We saw many states add accessible vote by mail. You may not know this, but states are already required under federal law to have a system where you can get an electronic ballot to vote absentee, because we require it for military and overseas voters. If a state already has it, all they have to do is open it up, at least to people with disabilities, to make vote by mail accessible for them. And I will say many states did. We pushed them and we pushed them hard, but they did. We did ensure access for a number of voters in long-term care facilities who we reached out to. We talked to long-term care ombudsmen. We talked to the staff in these facilities. We talked directly to voters. We made sure they were able to cast their ballots. We educated voters about their rights. We helped them make a plan to vote. And quite frankly, we voted. All of you, I feel confident, cast your ballot in 2020, no matter who you chose, no matter who you felt was the right person to lead the country going forward. I know and I believe that you cast your ballots and you helped everyone around you to do the same. And it worked. It worked. We actually saw the disability vote grow in 2020. You can see here, we have data from Rutgers that says the number of eligible voters with disabilities in the United States has jumped by 20% since 2008. There are actually over 38 million eligible voters in the United States. How many of them actually voted? That data is forthcoming. You're going to see that from Rutgers soon. But we are anticipating a jump for sure. It's already, we already have some good early indicators. We also saw reductions in barriers. This part to me is amazing, everyone. The new data that just came out from Rutgers shows that voting difficulties for people with disabilities declined markedly between 2012 and 2020. That's the article from The Hill that you see referenced here is talking about that research. A decline in barriers for voters with disabilities, a noticeable decline. This is something we fought hard for a very long time. About 1 in 9 voters with difficulties encountered difficulties in 2020. Now, that's double the rate of people with disabilities, but without disabilities, but it is an improvement. For people with disabilities who voted in person, 18% reported difficulties. That number is down from 30% in 2012. That is a several percentage point difference. And, even a few percentage points in an election makes a big difference. When we talk about the gap in voter turnout between people who have disabilities and people who don't, the gap tends to hover around anywhere from 5 to 8%. 5% doesn't sound like a lot. I didn't say we vote at a rate that's, 25% or 50% lower than people without disabilities. But when we're talking about millions of voters, a difference of 5% can easily be millions of voters, millions of voices that were unheard. So to see a drop in in-person voting barriers of several percentage points means that millions more voters were able to cast their ballots without coming up against those barriers that we have been able to see reliably from election to election. We had to fight hard, but the fighting that we did, it was worth it. We saw a huge shift to vote by mail. 5% of voters with disabilities had difficulties using the mail ballot. Only 5%. And that's compared to 2% of voters without disabilities. That's fantastic. 83% of voters with disabilities said that they were able to vote independently and without difficulty in 2020. That's down from 92% previously. We saw improvements. We saw people with disabilities casting their ballots, experiencing fewer barriers. And it's because we as a community, we worked so hard for that. We worked tirelessly for that. In the face of everything that was awful about 2020, I promised you that what I was going to speak about today was not going to be everything that was awful about 2020. Everything that you already went through, you already know. This is not the story of everything that was hard about 2020. This is the story of everything we did right in 2020. This is the story of everything that we fought for and won in 2020 in the face of unexpected and seemingly insurmountable odds. This is the story of a people who fought in 2020 to ensure that their voices would be heard, no matter what we were facing, when we were losing our jobs at a higher rate than our non-disabled peers, when our care was being rationed, when our life-saving medical technologies and medicines were being diverted away from our community. And in the name of research for this pandemic, we persevered, we fought. You see the amazing Monty Barbarin from Disability Rights Pennsylvania here. And a quote from her in 2020, she said, "You cannot stop me." And she was talking about voting. She was talking about her life. She was talking about her advocacy, but she was talking about her vote. You cannot stop her. This is not the story of everything that was hard about 2020. This is the story of a people who cannot be stopped. Access and inclusion in the ADA, they were tested last year. Everything was tested last year, but for people with disabilities, our rights, our access, our inclusion, they were tested in 2020. But this is the story of a people who rose to that challenge and had their voices heard in record numbers. I don't have to tell you everything that was hard about 2020. I know you went through it with me. I know I am talking to people today who lost people they care about. I did too. And when I look back at 2020, these last, few months that we've had into 2021, I promise you, I have taken the time to mourn what we lost in 2020. But when I think about 2021, I ask myself, where do we go from here? And the answer, when I think about everything that we fought for and everything we persevered, the answer is everywhere. We cannot be stopped. Just like Imani, we cannot be stopped. So I know that this past year was hard. I know it was difficult professionally. I know it was difficult personally. I understand everything that we have struggled through to get here. I was there with you. But when you look back at this past year, I hope that you see everything that we fought for, all the ways that we struggled, and everything that we won. When you look at the disability community and people with disabilities in the United States, I hope you think about advocates with disabilities in the 1980s who pitched themselves out of their wheelchairs and climbed up the steps of the United States Capitol on their hands to fight for the ADA. And I hope you see them again when you look at a year as grueling as 2020 and you see a people who could not be stopped, a people who will be heard, who will be vaccinated, who will fight for that priority to be vaccinated with our peers, who will fight to have our voices heard at the ballot box. When you look back at 2020, take that time that you need to process everything we faced that was big and scary and awful. Take the time to grieve everything that you lost. But when you look forward and you ask yourself, where do we go from here? I hope that you know the answer is everywhere. Thank you. I'm happy to hear your thoughts and answer any questions that you may have.
Thank you so much, Michelle. That was fantastic. Kim will be managing the questions, and we have about 13 minutes for questions.
All right. Well, good morning, Michelle. Thank you for being here. We have a few questions that have rolled in. I think so many of us were busy listening to you that we forgot to ask questions. So we'll see if we get more as we go. So here's our first question. You speak of a reduction in barriers and an increase in people with disabilities voting. This is wonderful. Can you expand on why there's a reduction in barriers for facility access? What's happening there?
So I wish I could tell you, ooh, I'm sorry, y'all, I got a little emotional, hold on. So I wish I could tell you that it was because suddenly everyone realized that we're right and they need to make elections accessible. I wish it was because suddenly everyone decided to start complying with the ADA and respect our civil rights. It was not for that reason. A lot of it though was driven by the pandemic. As odd as that is to say, right? As terrible as it is that we're in this pandemic, we had to face a lot of what was inaccessible about our elections. You know, a lot of the expansion in curbside voting wasn't because polling places are inaccessible. It was because they wanted to stop people who potentially have COVID from interacting with other voters and potentially infecting other people. Or at the very best, I'd say they thought about people with underlying conditions who need to limit their exposure, which I would argue, you know, if you did a Venn diagram of people with disabilities and people with underlying COVID conditions, there's absolutely a place where they come together in the middle and we're talking about the same people, right? We also, because the vote by mail became such a preferred method of voting in 2020, elections officials were extremely aware that they did not have the ability to process all those applications. Only so many people typically vote by mail in a given election, and that number increased exponentially in 2020. So things like allowing you to receive that ballot electronically, for us, that's an access thing, right? I want someone who can't, someone who's blind or low vision or doesn't have use of their hands to be able to access the ballot electronically instead of on paper so that they can do it privately and independently. That is your right under the Help America Vote Act. Do I think that's what drove it in 2020? Maybe if they got sued, but probably why that happened in 2020 is because they were aware that they could not mail out that many ballots in time. They didn't have enough time to process all those applications, and we did see challenges with the post office, of course, in 2020. They did not feel confidently they could mail out all those ballots in time, and if they were being smart, they had a backup system where you'd still be able to access it electronically. So we saw a lot of innovations that I think are really important for people with disabilities, that some are driven by us because we fight really hard for this, and some were driven by advocates that joined us in this fight when they really started to see some of the holes in the system that were really highlighted by running the COVID election. So hopefully, some of those changes were temporary. I think the challenge going forward is advocating in your state to make sure that good changes you saw in 2020 will be made permanent. And that's kind of our next big challenge.
Thank you very much. The next thing I'll share is a comment. We have a couple comments. Michelle, this was one of the most passionate and emotional presentations that I've ever heard. I applaud you and your commitment. With that, we thank you for your talk. This is the next comment. And what are some concrete steps you personally took to persevere?
Okay, so first of all, thank you. Folks who know me personally know I'm really passionate about voting. This really is my life's work. This is my first job out of school was as essentially a get out the vote organizer in the disability community. So this is what I have always done. I do talk about it all the time as though it is a critical life and death issue. I can't control it. So I'm glad that it spoke to some of you. I appreciate that. Oh my gosh, I talked for so long. I forgot what the question was at the end of that.
The question is, what are some concrete steps you took personally to persevere? You didn't talk that long. You're doing great.
Thank you. Oh my gosh, concrete steps. I mean, I tend to be eyes on the prize all the time. This election was coming no matter what. There was actually, interestingly, some discussion early on in the year. Could the election be postponed? Could the general election be pushed back? Or what will we not have a changeover of the presidency? That stuff is in the Constitution, right? That election, the November election, could maybe push back by at most about 2 weeks before violating the Constitution. The presidency, no matter what, ends noon January 20th when there's a changeover. And that's a hard and fast rule. So when you work in the business of elections, your deadlines are firm, and no matter what happens in between today and election day, the work has to get done. So it actually, we didn't have a choice, but it also gave me something to focus on, to be honest, other than being anxious and scared and sad about everything that was terrible around us. And that was really an anchor, I think, for me personally, and for a lot of the folks that I know. The work just has to get done. And I'm probably still clinging to that. We're still all at home, right? I'm talking about a little bit like it's over. I just got vaccinated, so we're not out of the woods yet. But and genuinely, I mean, looking at what did we win coming out of this? This was awful. I will always wish that what we went through in 2020 never happened. But what did we win and where do we go from here? To me, kind of keeps you going when it's hard.
Thank you. Our next one is, well, we'll see. The next question is a statement, really. So please comment on the Georgia law and effects towards people with disability. We can't stand in long lines. We need toilets, water, etc. What do you have to say about that?
I think what we're seeing right now, if I'm being very honest, in a number of states, including Georgia, is a pushback on what we won in 2020. We saw expansion of access to the vote. Because 2020 was so challenging, we really had to open up people's access to the process. And in a number of states, we're seeing some pushback on that. There are people who don't want to see that happen. And I think that's particularly obvious in Georgia. Why on earth do you need a law saying you can't bring water to people who are waiting in line to vote? That's not an anti-fraud measure. That doesn't serve any other benefit other than to make it difficult to wait in line, especially, look, it can be hot in Georgia when you're waiting in that line. You need that water. I did hear someone say, if we can't bring them water, we'll bring them Gatorade. And that was my favorite thing that I heard come out of the debate around the 2020 law. So, or the 2020 pushback that we're seeing in Georgia and these new laws. So I would say the work is certainly not done. We made some good progress in 2021. We didn't make enough progress in 2020. We saw some positive changes, but we didn't see enough of them in enough states. And we're seeing some pushback now. So unfortunately, being in the disability rights community, like, you don't ever get to rest. We never get to rest. Our work is never done. And that to me is one of the hardest things. You never get to sit back and say, woo, we solved that for people with disabilities. And so we're really still in the thick of it, and we'll continue to be, I think, right up through the 2022 midterms. So I think hang in there, and especially if you're in Georgia, keep fighting.
Yeah, I think that's about right. Our last question, I think, what has been your experience with addressing the voting access and needs of the culturally deafblind or those who have combined vision hearing loss? And on a related note, can you add ASL to vote access?
Oh, okay. Let me talk about ASL first. Love it. I talk about this a lot, actually, because I personally know a lot of people who are deaf or hard of hearing who don't think of themselves as a person with a disability. They think of themselves primarily as a speaker of another language, right? When a person who speaks ASL goes to vote, the primary barrier is not that they can't hear, it's that the poll workers don't speak ASL. And if we were all multilingual, it wouldn't be a problem. And so I talk a lot about how our elections officials need to think about ASL as a language access issue as much as they think of it as a disability issue, because they do think about how to provide access to speakers of other languages. And in many jurisdictions, it's required. Once a certain number of people whose primary language is whatever language, Spanish or whatever language it may be, they're required to provide access in those languages. And I really want our elections officials to think of ASL the same way. It's a language access issue as much as it's a disability rights issue. The one thing I'll say that I'm both happy and terrified that you asked about is access for people who are deafblind. We struggle with this constantly. The most honest, genuine, transparent answer I can give you is that we talk about this a lot. I don't know that we have truly great solutions. I don't know that we have truly great solutions. And I would even add to that, if there's anyone out there today who has good ideas, send them my way. Send them my way. The most important thing I have learned in doing this work is that all types of disabilities are different, and no two people who have the same disability experience it in the same way. So access for all types of voters, especially voters with disabilities, there's not one solution. There is no fix-all. It is an everything but the kitchen sink solution. We have to provide as many options as possible for voters so that they can find the one way that works for them. And when we start getting into people who are deafblind, people who have multiple disabilities, it starts getting really hard to have good answers. Ooh, I see some suggestions coming from the chat. Thank you. Put everything in the chat you can think of. We want it. We're hungry for it. But so the one thing I've learned in all of that is that the most important thing I can ever do in my work is listen to people with disabilities, tell me the barriers they see and the solutions that they want, and take that back to our elections officials and to our legislators and to try to make that happen. So any ideas that you have, please, please bring them to me. I will listen. I will be eager for that. And I think that we can come up with better solutions together.
So I'm going to ask one last question because it's just segues perfectly into this. How can we as people with disabilities get involved with NDRN?
Ah, I love that question.
Yeah, we thought that was a good one to end on.
That makes me so happy. We'd love for you to be involved in NDRN. The easiest thing you can do if you want to be involved in our work around voting and elections, we launched a new website in 2020. It's literally voterswithdisabilities.org. The most simple URL we could have found, voterswithdisabilities.org. We just launched it in 2020, so it has some resources on it. We wanted to have more. We'd love your thoughts on that. We'd love your help with that. We also try to feature a lot of videos of people with disabilities talking about the issues that matter to them and why they plan to vote. And it doesn't matter what the issues are. They don't have to be disability issues, right? We have videos up of I can think of one right now who is a Black woman with a disability who said the most important issue to me in 2020 is racial justice and police violence, as it should be. As a Black woman in America, that's not really a disability specific issue, but that's what mattered to her. And that's why she was going to vote. And that's why we need to make sure she has access. So if you even want to be a part of those videos or know someone who should be, we'd love that. If you go to our website more broadly, we do have some opportunities to reach out on some other issues as well. So we would love that. But if you start with our voting website, voterswithdisabilities.org, you would make my day. We want it to be a comprehensive go-to resource for people with disabilities, and we're still working on building it. So whatever you have to suggest or to show us that you think we should add to it, we would absolutely love that. Thank you.
Thank you, Michelle. I'll turn it over to Kurt for a few last comments before we go to our break.
Thank you. Thank you so much, Michelle. And I don't think I could have any comment other than your own statement about your passion, and we really appreciate that. We're going to take a 15-minute break, and we will resume at 10:05. We don't have a timer on the screen this time because we think that the timer may have caused some of the disruptions in the PowerPoint we had last time. So watch your clock, and we'll see you soon. Well, welcome back, everyone. We'll now begin looking at our 5 research presentations related to access and inclusion. Each presentation will last about 15 minutes. As a reminder, after the final presentation, we'll have a 20-minute question and answer period. And I encourage you to go ahead and submit questions as we go, and then we'll address those at the end for the question and answer period. We'd like to start out by welcoming Dr. Lisa Iazoni from Harvard Medical School, and she'll be discussing, and I'm going to editorialize here, what I think is an incredibly important piece of research that they have just published, her colleagues have just published, about physicians' perceptions of people with disabilities. So Lisa, take it away.
Thank you so much for having me. And this is one of the hundreds of articles I've published that hasn't just gone on a dusty shelf, but that people have actually been interested in. So I'm grateful to have a chance to talk to you guys about this. I'm a white woman. I identify as she, her. I've got curly gray hair, a woman of a certain age. I've had multiple sclerosis for 44 years, and I've used a wheelchair since 1998. Or 1988, sorry. Next slide, please. So there are 61 million Americans with disability, and these numbers are growing. And as the National Academy of Medicine said in their 2007 report about the future of disability in America, disability in America is not a minority issue. It affects today or will affect tomorrow the lives of most Americans. It's now more than 30 years since passage of the Americans with Disabilities Act, and more than 43 years since regulations were implemented under Section 504 of the 1973 Rehabilitation Act. Next slide. So why is it so hard to make healthcare fully equitable and accessible to people with disability? Next slide. Why in 2021 do people with disabilities still confront barriers and experience disparities in their healthcare? Next slide. Previous research has involved surveys, focus groups, and in-depth interviews with people with disability and have suggested some explanations, answers to those questions. Next slide. So for example, sometimes people's underlying health conditions might be complex and present competing priorities to routine screening and preventive services and under other healthcare where there are disparities. People with disability have disadvantages in social determinants of health. People with disability might have different preferences for care than non-disabled people. We all know about inadequate training of healthcare professionals about disability, ineffective communication accommodations for people with disability where they're healthcare providers. We know there still is inaccessible medical diagnostic equipment, including weight scales and exam tables. Physicians have inadequate knowledge about ADA mandates for equitable care. But physicians, we know qualitatively, also have erroneous assumptions about people with disability and have ableism attitudes. Next slide. So several studies have examined physicians' attitudes about caring for people with disability, but typically they've been within small geographic regions or institutions. Next slide. So ours was the first ever national survey of practicing physicians in the United States about their experiences with and perceptions of caring for people with disability. We are grateful for funding by the Eunice Kennedy Shriver National Institute for Child Health and Human Development. And because it was the first national survey, we were greedy. We wanted to cover a lot of topics, but we had to go shallow, not deep, as I'll talk about in a few minutes. So the results that I'm going to talk about here are about physicians' perceptions of people with disability. And these results were published in the journal Health Affairs on February 1st of 2021. Next slide. So I'd like to thank my research colleagues, Samia Rao, Karen Donnellan, and Nicole Agronic from Massachusetts General Hospital, Eric Campbell and Julie Resselem from University of Colorado, Dragana Balshek-Jagovich from University of Massachusetts, Boston Center for Survey Research, and Tara Lagu, who was at the time at Bay State in Springfield, Massachusetts, but has since now moved on to Northwestern in Chicago. Next slide. So we looked at physicians practicing in 7 specialties: internal medicine, general internal medicine, family practice, rheumatology, neurology, ophthalmology, orthopedic surgery, and obstetrics gynecology. Next slide. We developed our survey by first conducting qualitative research, first starting with in-depth individual interviews with 20 practicing physicians in Massachusetts. We then conducted 3 focus groups with 22 total practicing physicians across 17 states. And through these focus groups and individual interviews in the literature, we identified key topic areas for the surveys. We designed the survey iteratively by months of every other week conference calls. Zoom wasn't a thing at the time among us and our colleagues across the country. After we designed the first draft of the survey, we conducted 8 cognitive interviews and 50 pilot tests of the draft survey. And the final survey contained 8 modules with 75 questions. And again, it's broad but not deep. Next slide. So we randomly sampled practicing physicians within those 7 specialties from a national list of contact information about physicians. We eliminated trainees, VA physicians, locum tenens physicians, physicians no longer practicing, and physicians with some other less common attributes. We sampled 350 physicians in each primary care specialty and 140 physicians in each of the 5 specialties for a total of 1,400 in the sample. The Center for Survey Research at UMass Boston mailed paper surveys in October of 2019, along with a crisp $50 bill inside to incentivize physicians to respond. We also offered the option to answer the survey online. Next slide. The Center for Survey Research had information to track non-respondents, and so they made follow-up telephone calls and remailed the survey, but without the dollars this time. 84% of physicians answered by mail, only 16% online. The pandemic complicated our final follow-up, and so we actually didn't end up closing the survey until June of 2020, but our overall weighted response rate was 61%. The response rates varied narrowly across the 7 specialties from, let me see, the chat just went over what I was going to say. I think it was from 58% for neurologists, is that correct, to 63% for rheumatologists. Next slide. Okay, many findings on various topics, but what I'm going to focus on this morning is on physicians' perceptions of caring for people with disability. Next slide. So, top line findings. 82% of physicians report that people with significant disability have overall worse quality of life than other people. Only 41% of physicians are very confident in their ability to provide equal quality of care to people with disability. And 56% of physicians strongly welcome with people with disability into their practices. Next slide. Other findings, 18% of physicians strongly agree that people with disability are often treated unfairly in the healthcare system, and 80% strongly agree that understanding their patients with disability is very valuable to them. Next slide. So we also did multivariable analyses on the quality of life outcome and found few significant associations. Women physicians were much less likely than men to report worse quality of life for people with disability. The odds ratio for women was 0.58 with a confidence interval of 0.33 to 1.01 with a p-value of 0.05. The next one is barely significant, but I'll put it in there anyway. It's safety net physicians, in other words, physicians who saw more than 35% Medicaid patients in their practice are less likely than non-safety net physicians to report worse quality of life for people with disability. Their odds ratio is 0.59 with a confidence interval of 0.34 to 1.03. And here the p-value is 0.06. Next slide. We also conducted multivariable analyses about physicians welcoming patients with disability to their practice. And remember, about 56% of physicians said that they welcome people with disability into their practices. Women physicians are much more welcoming than are men. For women, the odds ratio is 2.29 with a confidence interval of 1.4 to 3.76, p-value less than 0.001. There were some racial and ethnic differences across the physicians, but the samples for underrepresented minorities were too small for me to feel that we could do rigorous statistical analysis on this. Older physicians were much less welcoming than younger physicians. Older physicians, the odds ratio was 0.58 with an confidence intervals of 0.35 to 0.97 with a p-value of 0.04. Physicians in private practice were much less welcoming than physicians at teaching hospitals with an odds ratio of 0.38, confidence interval 0.19 to 0.75 with a p-value of 0.01. Next slide. Couple more findings. Physicians who value understanding patients with disability are much more welcoming than other physicians with an odds ratio of 5.46, confidence intervals 3.03 to 9.83, p-value less than 0.001. And finally, physicians who feel very confident about their ability to provide equal quality of care are much more welcoming than other physicians with an odds ratio of 3.53, confidence interval 2.20 to 5.67, p-value less than 0.001. Next slide. Okay, so our survey has limitations. I've already said that we went broad but shallow, and that is because we had to conduct our survey in 15 minutes to get the response rate that we needed to get. And so although I can tell you these top line findings, I can't answer the question why. We did not include questions that explicitly link physicians' attitudes with their treatment decisions for patients with disability. It was not feasible in this type of survey to explore implicit biases, such as through the implicit association tests, which are conducted online. There were too few underrepresented minority physicians, as is true in the physician profession overall. There's like less than 5% Black physicians in the nation right now, to explore their attitudes. And finally, budgetary constraints limited the survey size, so we could not compare across specialties. We also could not include other relevant specialties such as geriatrics and physiatry. Next slide. So typically in surveys, there's something called a social desirability bias, where survey respondents answer the way that they think the public would want them to answer. And the survey gave physicians the option to say that people with disability have the same or better quality of life, but they didn't. 82% of them said that people with disability have worse quality of life than other people. And my belief is that this response about worse quality of life suggests strong confidence in their answer, that the physicians who answered this way didn't think that they were giving an incorrect answer. They thought that no one would argue with their response. And this raises questions about care for people with disability in times of scarce resources, our keynote speaker said, especially in this time of the COVID-19 pandemic. And given the potential biases of physicians, how can we ensure that people with disability get equal quality of care? Next slide. But here we have even more problems because only 41% of physicians feel confident in their ability to provide equal quality of care to people with disability. Now, this is in a profession that doesn't tend to be shrinking violets. You know, physicians tend not to be shy about saying how intelligent or good they are. And it was interesting, though, that physicians who do not feel confident are less welcoming of patients with disability in their practice. And so here again, we are 30 more years after enactment of the Americans with Disabilities Act, and it's pretty troubling that less than half of physicians feel confident about providing equal quality of care. Clearly, this must be addressed, but how quickly can that happen? Next slide. And so finally, especially in this time of COVID-19, why should patients with disability need to prove to their doctors that they value the quality of their life to get equal quality of care? Next slide. I always like to end with Independence Day. Thank you.
Thank you so much. That was great. And we want to note that Louis Krause from the Pacific ADA has asked that we post in the chat that the longer presentation that you made recently for one of our webinars is available online. So we encourage people to consider looking at that. Now, I'd like to introduce Kurt Johnson and Mel Toy, who are going to present on our work that we've completed on accessibility and healthcare access. Well, thank you, Kurt. I'm pleased to be introduced. I'm the principal investigator on the Northwest ADA Center at the University of Washington, and Mel Toy is the interim director. I assumed that role after Kathy Matrone, who many of you know, retired. And Mel Toy assumed her role after Michael Richardson, who had been the project director, went into the private sector. Next slide. I'd like to make some acknowledgements. This study is based on a manuscript that was published in Health and Disabilities. And the authors were Dr. Ann Ordway, who is now with Neidler, Chris Garbaccio, Michael Richardson, Kathy Matrone, and I was a senior author. It was published under support of grant number 90DP0095, and we have no financial disclosures or conflicts of interest. So as we've heard repeatedly, including immediately prior to this presentation, there's significant disparities in healthcare access for people with disabilities. And these include significant consequences. People receive less diagnostic services. They have differential health care outcomes, and they encounter numerous barriers in trying to obtain health care. And we know that from what, Dr. Iazoni, I see that we've misspelled your name. We'll fix that on the PowerPoint before they go out. But as she noted, people with physicians perceive people with disabilities to have lower quality of life and are less confident in their ability to provide care and may not welcome people into their practice. And it's a more complicated situation, but these are important variables. We also know that healthcare coverage is necessary and has improved with the ACA, but is not sufficient. Next slide. And ADA and healthcare are covered under Titles 2 and 3 of the Americans with Disabilities Act. Next slide. Oh, excuse me. There we go. So what are the research questions that we covered? Well, the first is, what are the current barriers to ADA healthcare access experienced by people with disabilities under Title II and Title III? What are the approaches used by healthcare entities to ensure equal access to healthcare for people with disabilities? And this work extends the findings of our colleagues, Harris et al., who mapped the landscape of ADA research and found that there was more evidence needed to support ADA implementation to understand the variables associated with successful implementation, and that there needed to be deeper interrogation of organizations to better understand what their practices were and how they had used information that was available to them about ADA implementation. Next question, or next slide. We used mixed methods, and we conducted focus groups and surveys of people with disabilities. The surveys were developed based on some work we'd done with communities of practice in our region about healthcare access, and we developed a survey with 55 closed and open-ended questions, partly based on an adaptation of the Washington Group short set on functioning and the survey of participation and receptivity in community for people with mobility limitations. We conducted cognitive interviews on the questions to make sure that they were understood in the way that we expected them to be. Our survey respondents were 562, primarily white women with a variety of disabilities, but most had some limitations in mobility, and they were mostly from urban settings. And it was a convenient sample. We reached out to independent living centers and used snowballing to increase the sample size. We also conducted 19 focus groups, and the participants in those were primarily white women, but they were more likely to be from rural areas, low vision, blindness, hearing impairment. And that was a purposive sample where we reached out to try and recruit subjects that were not represented in the initial survey. And then for question 2, we conducted key informant interviews with 11 healthcare providers, including ADA coordinators, providers, and a physical therapist. And again, this was a purposive sample. Next slide. The results for question 1 were that people required having difficulty accessing everything from exam tables to weight scales to medical diagnostic equipment to exam chairs, and providers didn't have knowledge of even how to conduct transfers. And I'm going to pass this to Mel, who will talk about the results from the focus groups, since she participated in those.
This is Mel. Thank you, Kurt. I'm an Asian person with dark brown hair pulled back, and I'm wearing a headset, glasses, and a light gray cardigan over a black and white shirt. My background is solid purple. It says the University of Washington and has a giant W on it. So I just want to take a few minutes to talk about some of the stories that we heard coming out of our focus groups. And we held 3 focus groups in 3 of our states in the northwest part of the country, which is also called Region 10. Those states were Alaska, Oregon, and Washington. In Alaska, we heard about the difficulties with transportation to and from medical appointments. More than one participant in Alaska talked about traveling from Alaska to Washington State, where they had their medical appointments in Seattle. So you can imagine the type of transportation that's entailed there. Air travel, ground transportation, and even an overnight stay in Seattle. And they experienced long wait times between different types of transportation. Sometimes they weren't even picked up by the taxis. And then after enduring a long day to get to their hotel in Seattle, where they were supposed to get an ADA accessible room, only to find out that it wasn't accessible to them. In Alaska, we heard a lot about inaccessible diagnostic medical equipment. One of the participants shared that he didn't know how much he weighed. He hadn't been weighed for 5 years because his provider got rid of the wheelchair accessible weight scale because no one was using it, he said. So he hadn't been weighed for quite some time, and he had no idea how much he weighed. Also, he experienced difficulties transferring from wheelchair to exam tables and exam chairs because there was no assistance by the healthcare provider. There was no skilled lift team at the clinic. There was no Hoyer lift, etc. And then in Washington State, this was a unique focus group in that all of the participants had a visual disability. That was one thing they shared in common, and a strong theme that came out of this group, something that Dr. Iazoni talked about, was the provider perception or provider attitude as the barrier to accessible healthcare. So we heard stories from people who said, you know, they approached the front counter to check in for their appointment, and they were told by the staff person, oh, you need to wait for your sign language interpreter to show up. And the patient said, I don't need an interpreter. I'm blind, but I hear you just fine. Please remove that from my chart. So having an awkward conversation there. Another participant shared a story where they were sitting in an exam room waiting alone, and they heard someone come into the room who did not identify themselves and then had started touching the patient without permission or any kind of announcement, and how startling that experience was for the person. We also heard about providers issuing equipment for the person to take home. For example, there was a heart monitor that was issued to one of the participants, but no instruction was given. And it was assumed by the provider that the person had someone at home to help them. And when the person said, you know, I really need some instruction, they were told, well, you know, just get a family member you live with, someone you live with, to help you work this equipment. And the person said, I live alone. I've lived alone for many years now. And it really surprised the provider. So the provider said, well, why don't you take it to your neighbor? I'm sure your neighbor would love to help you work this piece of equipment. And when the patient said, you know, I'm not going to do that, that's really a strange thing to do. I would not feel comfortable doing that. The provider decided that the equipment was not necessary for the person to take home. So I just wanted to recount some of these stories as best as I could, just to give you some examples of what we heard during our focus groups. And with that, I'll go ahead and turn it back over to Kurt. Thank you.
Thanks so much, Mel. We think that the qualitative data that came out of the focus groups is probably in many ways more informative than what we got from the survey. From the key informants, we heard that they were concerned about their lack of access in the healthcare system to ASL interpreters, and that mirrors concerns from some of the respondents who complained that they didn't have access to interpreters. They noted the lack of that they had a lack of training on how to transfer people. They discussed the issues about late and no-show policies that may result in hospitals dropping patients with mental health issues. And I'll note that that's also an issue for people with traumatic brain injuries who may forget they have an appointment and not show up and then get dropped as patients. And the accommodations may not be included in the medical record. So there may not be any history available within the electronic medical record to let them know what kinds of accommodations had been requested. Next slide. So in our discussion, we observed that, as have many others, that people with disabilities continue to experience significant barriers in accessing healthcare. Healthcare providers lack training in critical disability issues, and perhaps that should more thoroughly be addressed in pre-service education. I know that at our School of Medicine, all of the physicians in training get education from some of our staff on issues key to disability, but that's not universal. Healthcare systems may not be nimble enough to make responsive changes quickly. Healthcare systems have an incredible amount of inertia that's driven partly by fee for service and partly by payers. One of the things that we've noticed in employment is that we've been asking for years to have work at home be one of the options for employment, with some concerns I add. And that with the pandemic, all of a sudden that's available to everyone. Well, with healthcare systems, we now have robust use of telemedicine, which has its own limitations, but is incredibly convenient for people to not have to try to get to the healthcare settings. And after a couple months of pandemic, there was actually a way to get reimbursed for that. That reimbursement is likely to change. And it would have been hard for healthcare systems to make those changes without changes from CMS. Comprehensive examination of applications of the ADA in healthcare is important, and the systematic enforcement of ADA is warranted in healthcare. And I reference back to Sachin Pivarathan's observation that they're now working further on the standards for accessible medical equipment at the Access Board. And with that, I want to thank you for your attention, and we will be welcome questions when we get to the question and answer period. Now I'll revert to being Kurt Johnson again. And thank you, Mel, so much for participating in that. We really appreciate that. And we're going to move on to Dr. Wynn and Dr. Monique Papadis from the Southwest ADA, and they will be discussing their research about service animals. And I think Vin is going to begin.
Yes, thank you, Kurt. Next slide. All right, ADA regulations define service animals as any dog that is individually trained to do work or perform tasks for the benefit of a person with a disability. These tasks could include, among other things, like pulling a wheelchair, retrieving dropped items, alerting a person to a sound, reminding a person to take medication for their chronic health condition, or performing physical tasks like pressing an elevator button where a person can't do that. And of course, most people understand what a seeing eye dog or a guide dog that helps people without vision to navigate through the public. Generally, they are allowed where the person is allowed to go in public. And the ADA also prohibits public facilities from applying a surcharge. You usually see that with hotels and motels where anytime you bring an animal or rent a room and have an animal, they try to apply a pet deposit or some type of animal fee. So that, the ADA prohibits that. The establishment can only ask two questions. Is the animal required because of a disability, and what work or task it is trained to perform? The establishment cannot probe about the disability. That means like they cannot ask extensive questions about the person's disability or try to make the person prove the disability. And then they cannot make the person prove that the dog is actually a service animal, that they cannot require some type of certification or proof of training. What I forgot to mention is that there are also animals known as emotional support animals and comfort animals, or therapy animals, and those are not protected by the ADA. The key word in defining what a service animal is that they're trained to perform tasks, and animals such as emotional support animals, comfort animals, provide a benefit to people with disabilities only by their mere presence. So they're not necessarily trained to assist a person with a disability. The topic of service animal is easily the most popular topic that the ADA National Network receives on our phone lines, through emails, and in 2014, the Southwest ADA Center published a booklet expounding on the issue of service animals, and it is easily the most popular and most downloaded publication from the ADA National Network website. Next slide, please. So I think about 2 or 3 years ago now, it's been a while, our ADA Center was curious about what types of barriers or experiences people with service animals were experiencing out in public. And the title of the slide, or the header of the slide, is actually a little misleading. This was easily our most popular survey that we've ever done, and we had 1,250 people that use assistance animals respond to us. Not all of them were dogs dogs. I think we had like maybe 10 people that said they'd had cats as emotional support animals because from general experience, training a cat is very difficult. But we had the super majority, like 99% of the survey takers did utilize a dog, and the tasks that these dogs or these animals perform were broad. Almost half did some type of physical task, while almost another half did tasks that assisted people with psychiatric disabilities. In terms of training, because we used a convenience sample that where we approached both disability organizations and service animal organizations, including their trainers, to recruit our participants. We also had a varied amount of people that had different types of dogs in terms of training. More than half were professionally trained, and again, that may be due to sample bias. 33% were trained the dogs themselves. 12% actually had someone else. It could be, and we didn't have them specify who that someone else is. It could be like a family member. And then, as I mentioned before, 3% of the respondents had untrained emotional support animals. In terms of like the demographics of the people themselves, 65% had a disability that they would say was invisible or hidden or not obvious. And even though the ADA does not require people to identify their dog through a tag or a vest, almost 91% of the users said that they identified their dogs with some type of vest or tag. They 50% or over 50% said that they got this identifying gear from their trainer, while 40% said that they got it from some other sources, and 6% said that they made it themselves. We found that, when it comes to gear that they obtain from a non-trainer, most of them mentioned that they got it through the internet, through some vendor. Next slide. So in terms of the barriers they reported, I was a little surprised by the numbers, but over 50% said that they had never or rarely been denied access with their animal. And I thought that figure was a little high, but that is what we had. But a good 44 or 45% said that they sometimes or frequently were denied access or felt unwelcome. So those were the participants that we were really interested in focusing on. About 40% of the respondents said that they were probed inappropriately about their disability, while 90% of our respondents actually said that they were asked to prove their animals training through certification or license. In terms of the types of establishments were that denied access or caused issues in terms of the barriers experienced. No surprise, the most popular industries were food services. Like over 80% of our participants said that they had problems either at a restaurant, bar, or a grocery store. With transportation, and I'm not talking about public transportation, I'm talking about private transportation like taxis and Ubers, Lyfts. Almost 50% said they had issues there. 32% said that they had issues at medical facilities, and 10% said they had issues with lodging, such as hotels and motels. Other demographic factors that led to their experiencing barriers were that if you were female, non-white, had a hidden disability, or did not, the 10% that did not have identifying gear on the animal, and you were more likely to experience issues. One other factor that we found that we were a little surprised, but it might be a reflection of the training, was that it seems like the public seems to recognize whether the person trained the animals themselves, because we noticed that they experience more barriers, or people that train their own dogs experience more barriers than people that had their dogs professionally trained. Next slide. At this point, I'd like to switch it over to my colleague, Dr. Monique Papadis.
Hello. For the second phase of the project, we did deliberative dialogues, which are essentially where we take diverse groups of individuals who represent different groups and to come together to discuss different issues. So we presented to them to be able to identify specific barriers that they've experienced related to service animal use, and then also to discuss, potential concerns that they may have related to different industries, and then also came together to discuss solutions or recommendations. So we put together a stakeholder group of 7 individuals. 4 individuals were service animal users, where they had dogs performing different tasks. We also had 2 representatives from the lodging industry, 1 from food service, 2 from healthcare industry, and then 2 from transportation. So there were several barriers that were identified by the group that where they reached a consensus, is that there's this explosion of fraudulent animals. So basically, many individuals bringing pets to different places under the assumption as if they were and calling them service animals. Also, they had concerns about pets causing danger to their trained service animals. So specifically where non-trained dogs or pets can sometimes provoke the service animal. And then another barrier identified was that individuals and industries not really understanding the ADA rules around or surrounding service animals. And so, industries, business owners, as well as employees may not know as much about, the do's and don'ts in regards to service animal policies. And then the majority of industries and business owners, as well as employees, do not know how to specifically identify service animals as opposed to pets. And so many of the stakeholders involved, I did mention that the 2 questions that Mr. Venn had mentioned, that they aren't allowed, it's not sufficient information to properly identify a service animal, and leave some type of question about whether or not the animal should be permitted. Next slide, please. So they had a significant number of recommendations. One is consensus on about the revision to the ADA to address the misrepresentation of pets as service animals. Also, the development of some type of certification or accreditation process to be able to confirm that the animal has been trained. And then the process, also having a process that entities or industries can use to be able to successfully identify and verify whether or not an animal is indeed a service animal. In addition, they recommended that trainers should be licensed by the state or federal government to train or be able to accredit service animals. and that government should recognize certain organizations as qualified to certify both the service animal as well as their trainer. In addition, they also mentioned about needing to educate service industries as well as the general public about ADA, the ADA and service animal use. And many of them made suggestions about the need to have some type of ad campaign or public awareness surrounding service animal use. Next slide, please. So the next steps to strengthen our study findings is that persons with disabilities will have a better understanding of potential challenges with service animal use before seeking ownership of a service animal, as well as being able to support those conversations between providers and clients prior to prescribing the service animal. Also, a fact sheet could be disseminated to increase their awareness of use of service animals in a variety of different settings, as we mentioned previously. And then online training modules could be developed to help increase awareness and knowledge, as well as design specifically surrounding those industries where many barriers occur. Again, food service, hotel or motel lodging, transportation services, and in addition in the healthcare setting. And then also next steps, what we would like to do is to really explore the strengths and barriers to service animal use, but focus specifically on the workplace settings. So thank you.
Well, thank you so much, both of you. You're right on time. You left out a slide. People can reference that. Let's move on now to Doctors Michelle Putnam and Carrie Morgan. We're going to talk about aging with a physical disability. And so I think, I'm not sure which one of you is going to start. I think Michelle.
Mm-hmm.
Excellent. Yes. Take it away. All right.
Hello, everyone. My name is Michelle Putnam. I am a white woman with short brown hair. I'm wearing all black today. I have on glasses and a blue background behind me. So the title of our presentation is Participation, Accessibility, and Aging with a Physical Disability. Next slide, please. This study is part of the longitudinal study of aging with a long-term disability. This presentation is. The study is being done in a center called Cedar Midwest, and it's Community Engagement for Disability and Aging Research. What did we want to know when we did this analysis that we're going to talk to you about today? And what did we want to know about for this longitudinal study? We wanted to develop a better understanding of the interaction of aging, disability, and participation over time. And we wanted to understand if changes are related to growing older, functional ability, factors in the community, such as accessibility, services and supports that help people participate, and other personal and community resources, or if it's related to all three. So we wanted to know if it was your disability, you're growing older, or what's in the community, or all together. Next slide, please. Why did we want to know this? Well, people aging with long-term physical disabilities are an understudied population. We don't have a lot of research on this group of people and aging with disability. But we know that people who are aging with physical disability, that includes people living with long-term effects of physical disabilities acquired from birth to middle age, who are surviving into middle or late life. That's really the population group that we're focusing on. And we know that for that group of people, when the aging process begins, as they age, people with physical disabilities start reporting greater difficulty associated with their main condition, and that starts closer to ages 45 and 55. Sometimes people refer to this as accelerated aging, but we're mostly thinking about people who feel like they're growing older a little bit earlier than the rest of the population. Next slide, please. So what was our study? So this is a multi-year internet and phone-based survey study. It's a cohort that we're following, and we're collecting data over three time periods over a 5-year time period whole. And to be included, you had to be 45 to 65 years of age. You had to have your disability for 5 years or more. And in this case, you needed to be English speaking. The exclusion criteria, the only one we really had, was that if you had a cognitive impairment that limited your ability to self-report or answer the questionnaire, then you were excluded from the study. Our recruitment was primarily community-based. This is a community-based research project. We have a network that we use called our Community-Based Research Network. So those are partners and community-based organizations that we work with to recruit people. So that was our main source of recruiting participants. And we also recruited through social media. Most of our participants are coming from the St. Louis area, where the Cedar Midwest Center is based at Washington University in St. Louis. Our first survey that we gave, so our year one, our baseline survey, we had a sample of 475 people that are included in that survey. The survey is repeated 1 year later, so the anniversary of your first taking it, and then 1 year later after that. So that's our year 1, 2, and 3. And my colleague, Carrie Morgan, will say a little bit about this. Our time window is an interesting one because our first wave of data was collected before the pandemic. Our second year of data was collected partially before the pandemic and then in the pandemic, and our third year is being collected now. So we will have an interesting look at change over time, and we'll be factoring in the pandemic, which is kind of new, to try to think about how that fits in. The questions and survey, the items on our survey are really in 5 domains. One is we collect a lot of information about demographics. So everything from who you live with to your income level, to work and employment information. Another domain is health. So asking about self-reported health, chronic conditions, disability-related symptoms when we think about aging with disability. We have another section on participation, so things that you do, activities that you engage in. We have another section that asks about resources, including supports and services that you might receive in the community. And then we have a section on the environment, including facilitators and barriers, things that help or things that get in your way for you doing the things that you want to do. So that is the setup of our study. And now I'm going to pass it over to Dr. Carrie Morgan, who's going to talk a little bit about our initial findings.
Great. Thanks, Michelle. Hi, I'm Carrie Morgan. I'm a white woman with brown hair. I'm wearing a black shirt. I have a background screen on my Zoom that's gray with a Washington University logo. I have a disability and I use a manual wheelchair. So Michelle introduced the research study to you, and I'll now review some of the results. I'm going to start by describing the demographics of our 475 participants. So we first asked participants to identify the health condition or impairment causing their physical disability, and there were many different diagnoses and health conditions reported. So what we did was we coded the responses, and the most frequently reported health conditions fell into 3 groups: musculoskeletal, and some examples of this were osteoarthritis, spinal stenosis, amputation. Second group, neurological, examples were cerebral palsy and multiple sclerosis. And the third group was immunological, which included things like rheumatoid arthritis, connective tissue disorders. Participants had a mean age of about 57 years old and about a mean of about 19 years of living with their disability. The cohort was predominantly female, And over 1/3 of the group identified as non-white. This is really important because the only other cohort that we know of that was similar on aging with a disability that looked at specifically health was 94% white. And so really we made an emphasis in recruitment to try to target a more diverse sample. The majority of our cohort was not employed, with 60% reporting being on disability leave. Next slide, please. Did that slide advance? There we go. Thank you. 3 symptoms are commonly reported in the aging population. They're fatigue, pain, and depression. So we wanted to examine these 3 symptoms for our cohort. So there's a figure on the slide, and the x-axis shows these 3 symptoms, and the y-axis is the score on the measures used. The higher the score, the higher levels of the symptoms over a 7-day period. The general population average score for these 3 symptoms is 50. So what this figure shows is that each of these 3 symptoms for our cohort are higher than the general population. Next slide, please. This slide is set up really similar to the previous slide, except rather than looking at aging symptoms, we're looking at participation. So on the x-axis, we have 2 participation measures: ability to participate in social roles and activities, and the second one, satisfaction in participating in social roles and activities. This time, the lower the score, the less ability and satisfaction people reported in participating in social roles and activities. Again, the general population average score is 50. So our participants reported scores lower than the general population. And we looked a little bit closer at this and found that participants with lower scores more often lived alone, had lower incomes, and reported worse physical and mental health. Next slide, please. So we're really interested in what people aging with disabilities are doing in their daily lives and what they're doing every day and what supports they need. We looked at 9 different activities throughout their day. A few examples of these activities are socializing, employment, chores around the house, and managing medical conditions. And what we really learned is that people aging with disabilities are doing a lot of things. We looked at demographic characteristics to see if the demographic characteristics associated with what people were doing, and we did not find any associations. So we looked more closely at different activities, and I'm going to share one of those activities with you today, which is physical activity. I selected this activity because this is the activity that had the highest number of participants reporting that they wanted to do more of. So we had 66% of our participants report that they did some level of physical activity. Of the participants that reported they were doing physical activity, 59% reported that they still wanted to do more. So they were doing some, they wanted to do more. Of all the participants not doing any physical activity, 76% reported wanting to do at least some physical activity. And they really identified that they were going to need support in 4 different areas if they wanted to engage in this activity more. And those 4 areas were needing more personal assistance, needing the proper environmental modifications and proper assistive technology, and overall improved health. The participants that reported doing physical activity had lower scores of fatigue, pain, and depression, and higher scores of social participation than our participants who were not physically active. Next slide, please. So I told you about the 9 activities that we looked at. We had an open-ended qualitative question at the end of each of the 9 activities that asked about what supports they would need to successfully participate in these 9 activities. And what we found, and probably no surprise to this group, is that people aging with disabilities experience a wide range of factors that impact whether they're being able to be independent and participate in society. Participant responses highlighted an equal combination of environmental or extrinsic factors and personal factors or intrinsic factors. Physical effects of disability and accelerated aging like pain and fatigue paired with environmental factors such as accessibility of transportation, which was a big one that was identified, were reported as influencing participation in daily life activities. Next slide, please. So as Michelle mentioned, the timing of our cohort study is that our cohort study is happening during COVID. The data that I just reported to you was prior to the COVID pandemic, but the follow-up surveys did happen in the middle of the pandemic. So what we did was at the beginning of the pandemic, we put together a survey, a short survey, to figure out what people's experiences were during COVID. So 186 people out of the 475 responded. And we're still going through this data, but what we're finding is that a small percent of participants have actually been diagnosed with COVID. Most participants are actively engaging in social distancing, and there is increased food security, meaning people are having issues more so in the pandemic of accessing the food and when they need it. And that there was challenges in completing ADLs due to lack of available human assistance.
And Carrie, this is Kurt interrupting. We're just about out of time.
Okay, great. Thanks, Kurt. I'll wrap it up. Next slide, please. So what can we learn from these findings is that although participants are doing activities in their daily life, like physical activity, they may want to do them more than they're doing them or do them less than they're doing them. And in many instances, they're not satisfied in how they're doing them. And that there's really a host of intrinsic and extrinsic factors that contribute to that. Next slide, please. Last slide. So we're still actively analyzing our data, and our next steps right now is we have a lot of information about accessibility and the physical environment and services people are receiving in their communities. And that's what we're looking at right now. Thank you for your time. Next slide. And I look forward to any questions.
Thank you so much, Michelle and Carrie. That I know represents a piece of a lot of ongoing work that you've been doing, and we appreciate it. Next up, we're going to look at the ADA Participatory Action Research Consortium, and today we have Joy Hamill and Jacqueline Kish. Joy, you want to kick this off?
Excellent. Thank you, Kurt. What I'd like to do, first of all, is start by acknowledging our funder, which is the National Institute of Disability Rehabilitation and Research, and also a visual description of myself. I am a white female in my late 50s, brown hair, brown eyes, green shirt. I also use the pronouns she and hers, and I self-identify as a disabled woman, activist, and participatory action researcher. Next slide. And that gets us into the action research we've been doing within ADA PARC. ADA PARC stands for the Americans with Disabilities Act Participation Action Research Consortium. And it's a consortium of all 10 regional ADA centers, along with action researchers from several universities, and then an outreach to hundreds of different disability organizations. Next slide. What are we interested in and what do we want to know? Well, we took the mandate straight from the disability rights community. What they wanted to know is, since the passage of the Americans with Disabilities Act, which is now going on 30 plus years, how are people with disabilities faring? Are they getting equitable access to participation opportunities in our society, or are there disparities? And specifically, they asked us to look at large data sets, census level population health data, so they could see it broadly. And they wanted to see it in several different areas of participation. So we are documenting across community living, community participation, and work and economic equity. Next slide. What I'd like to do in the rest of the presentation is focus in on an example of how we take this very large scale data, population health data, and translate it back to local communities so that they can actually use it and take action on it. And the example I want to use is a project we did with the Metropolitan Mayor's Caucus, which represents over 275 cities, towns, and villages throughout Chicagoland region in Illinois. They also have diverse stakeholders, including the mayors themselves, but also politicians, policymakers, government officials, urban planners, transportation services, social services, and disability groups. So they're in a very strong position to affect policy and systems changes in their communities and across the entire region. And the way they heard about ADA Park is through Robin Jones, who's director of the Great Lakes ADA Center and had been working with them for many years on ADA-related training and technical assistance. She talked about what we could give them from an ADA Park participation disparities perspective, and they said, yes, we want to know that in our communities. Next slide. And so we used a participatory action research approach that was called appreciative inquiry. And what that involves is working with communities to identify participation issues and strengths in those communities, to vision dreams and aspirations of where they'd like to be, and to set concrete action goals to get there. So the Mayor's Caucus in this case chose 4 diverse communities that we would start with to feature them, to give the rest of the whole caucus an idea of what's possible. And these communities represented different geographies and very diverse constituencies within them. They then invited those key stakeholders to participate in community forums. We happened to get all these in right before COVID hit, but we're now moving to an online forum to continue the discussion. They asked us at ADA Park to give short presentations on what's happening with disability in their communities, so disparities reports. And then they facilitated small breakout groups with the stakeholders to strategize how to use those findings and prioritize actions. And then ADA Park took their information, put it all into a community report, added some more information they requested to it, and gave it back to the communities so they could use it in their actions. Next slide. So I want to give just a few examples of what happened in those forums and in those community reports. So one of the first things we start with every community is just kind of talking about what does disability look like in their community. So we give them a report on the number of people with disabilities, the percentage of the population that represents, their different ages, different types of disabilities, different ethnicities and races, different economic status. And we give them that report to start with. And that's where you can begin to see some differences already between communities. So we know 3 of the communities that we focused in on had higher rates of percentage of people with disabilities living in them than another one in Naperville that only had 7%. Next slide. The next thing we did then is went through a whole series of information on how are people with disabilities participating in each of these communities, and that community living, community participation, and work and economic participation. And for example, on this slide, you're seeing percentage of people with disabilities who are employed in those communities according to the American Community Survey. And here we start to see also some disparities. So 2 of our communities, Hazel Crest and Chicago itself, have fairly high rates of unemployment, fairly low rates of employment. So around 31%. Whereas we see in our other 2 communities, Naperville and Arlington Heights, they have much higher rates of employment, anywhere from 48 to 50%. So again, targeting those communities to see, is it just a demographic thing, an income thing in them, or are they doing some promising practices that could be replicated? We also went ahead and talked people through what unemployment looks like, and also not in the labor force, which means people with disabilities who've been out of the workforce for an extended period of time. Next slide. And then we went into a whole analysis of economic equity, and particularly since so many people with disabilities are not employed, we looked at what are the percent that are living below poverty, which is $13,000 approximately or less in the United States right now. And here's where we can see disparities on multiple levels. So first of all, we know two of the communities here, Hazel Crest and Chicago, have much higher rates of living below poverty. Somewhere around 32 to 35% of the people with disabilities in these communities are living below poverty, which means that 1 out of 3 potentially people with disabilities are living on $13,000 or less per year, which is no small feat in these communities. Whereas when we compare it to Naperville and Arlington Heights, we see almost half the level of poverty there. So again, worth looking at what's going on, what are the differences here. But not only can we compare between communities, we can also compare people with disabilities to people without disabilities in the general population. And this is where you see that people with disabilities are 3 times more likely to be living below the poverty level than people without disabilities. And I would have to say just this one slide, this one piece of information was probably the #1 thing that community stakeholders looked at, shook their heads at and said, boy, that's not a good thing for us to have in our community. What are we going to do about it? Next slide. And then finally, we began to do some visual mapping with them in the community. So what you're seeing here is a GIS map of a community, Hazel Crest, Illinois. And what the map shows is it shows how Hazel Crest is situated, where the neighborhoods are. And what we overlaid on top of that is where do people with disabilities live in those neighborhoods. So the darker the color, the orange, means the greater percentage of people with disabilities are living there. And what we can see in a more accessible format from this is that we can say to Hazel Crest that they have greater percentages of people with disabilities living in their northeast and mid sections of Hazel Crest, which was really important to the communities to show where are some of the zones that potentially are most restricted in terms of their participation, assets, and resources, and what could we do about that. Next slide. And now I'd like to pass this over to Jacqueline Kish, my colleague, to continue the presentation.
Hi, thank you, Joy. My name is Jacqueline. I'm a PhD candidate working on the ADA Park project. I use pronouns she and her. I'm a white woman in my 30s. I have glasses and short dark hair. I'm wearing a dark shirt today, and I'm going to continue talking about GIS maps. This slide shows 2 examples of GIS maps where people with disabilities live in orange, but we've overlaid the bus lines on top of that in blue. And we've also done a spatial analysis that shows that 99% of people with disabilities live within a 1/4 mile of public bus in Chicago on the left, and only 71% do in Houston on the right. So these maps can be used to identify disparities to influence action, as well as to compare access between cities. Next slide, please. Here's another slide of the 2 samples of GIS maps where people with disabilities live and their proximity to rail services overlaid in blue. Rail access is typically less than bus, but Chicago again shows better access or proximity than Houston, where in Chicago, 49% of people with disabilities live within a 1/2 mile of public subway or train, while only 10% in Houston. So the intention of showing this to the participants in the Mayor's Caucus meetings was to demonstrate that spatial analysis can give us some important information, and also to find out how this information would be helpful to this group of stakeholders. We worked to initiate a discussion on the ways to assess access, with these maps being just one example. Next slide, please. This next sample is 2 GIS maps that show access to transportation across a region. So here's a map of the San Francisco Bay Area showing where people with disabilities live in proximity to bus on the left. 97% of people with disabilities are in close proximity, and then to rail transportation on the right, where 32% live in close proximity. It's important to evaluate transportation regionally. Many issues identified by people with disabilities occur in coordination of services across the region as opposed to just within one city or within one system. Next slide, please. So after we presented these disparities reports, we asked the attendees what the priorities for their community were, how they could use these types of data, and how we can create meaningful change. Next slide. So the findings from the community meetings are compiled here. I want to say that far and away, the biggest request for the ADA Park was for a regional analysis of public transportation. And maps that show where sort of the black holes or stark lack of access were for people with disabilities to directly impact advocacy efforts in these areas. Some other great suggestions that we received were asset-based, including championing coordination efforts and municipalities that are good examples of adapting policies and allocating funding for improved access to resources for people with disabilities. And then additionally, to transportation, a number of other community participation domains were identified, including affordable accessible housing and social and community participation to address social isolation. Okay, I'll hand it back to you, Joy.
Okay, next slide.
Joy, this is Kurt. We're running out of time.
Okay, so what can we learn from the findings? Well, these community reports were incredibly valuable to the Mayor's Caucus and to all the other communities we've worked with across the ADA region as a way for them to take that information, that research, and actually put it into action and then work with the Americans with Disabilities Act centers to actually get there. And next slide. And finally, we're taking a lot of steps to strengthen, the ADA Park outreach and research as well. One I just want to highlight is we are now updating and doing major revisions to the ADA Park website so that the communities can automatically get these community reports downloaded and just select a city, get an infographic that tells you all about what's happening, get a map that also tells you about where people with disabilities are living and where some of the disparities are. And so that's where we're headed. That website will be going live to the public in June. And so we invite you to be a part of it and to help us get the word out about it and to help us evaluate it. Next slide. And just a special thank you to all the ADA Park Consortium collaborators and participants. And if you'd like to get a copy of some of these community reports or our website's listed there, as well as you can email me for copies of the reports or if you'd like your community featured. Thank you.
Thank you so much, Joy and Jacqueline. I strongly recommend that you go explore that website. It's got an amazing amount of data and you may find it useful in some of your work. Now we're going to move to our question and answer period. And I'm going to pass this to Kim, who has been monitoring the questions that you've asked.
Thank you all for all of your presentations. We have a few questions to start with. We'll start with Dr. Iazoni. Can you tell us why VA physicians were excluded from the study?
Yes, this is Lisa. VA facilities often are more accessible by design than non-VA facilities, specifically because the types of patients that they see have service-connected injuries or diseases. For example, at my local VA hospital, the elevator doors close more slowly than in other hospitals because they want wheelchair users to be able to get off the elevator before the doors close on them. So we did not feel that, that the experiences at VA facilities would necessarily generalize to physicians practicing in the regular community.
Thank you, Dr. Iazoni. Our next question is for Kurt and Mel. You mentioned systemic enforcement of the ADA in healthcare. And that happens only if there's filed complaint of discrimination or if the facility, or possibly an element like diagnostic equipment, is being altered or built new. Do you have suggestions for enhancing these limited avenues of enforcement?
Well, it's a great question. And I know in the disability studies class that Dr. Mark Harness and I teach, the students constantly come up with a complaint about the degree to which ADA enforcement is complaint driven and about the burden of enforcement is on consumers. I don't have smart answers about this. So we have a couple of things going on that we've seen locally. One is the increasing sophistication of ADA coordinators in healthcare systems who can take the lead in organizational change. And we see that probably, Mel can correct me, but I think probably most significantly in healthcare organizations like Kaiser, where the ADA coordinators have been quite active in at least some areas of Kaiser. But it's a toughie.
Thank you, Kurt. Our next question is for Vin and Monique. Were you able to get a sense of the service animal users' understanding of their rights and responsibilities under the ADA? Was there a difference between handlers who trained their own dog versus handlers who had a dog trained by a professional?
Since we, use a convenience sample approaching disability organizations and service animal organizations, the people that we surveyed were pretty knowledgeable about their rights, and we could not distinguish between those that trained their own animals versus using a professional trainer.
Thank you, Vin. I'm looking for my next question. For Carrie and Michelle, thanks for the introduction to your great study, Dr. Putnam and Dr. Morgan. What are some of your thoughts or plans for analyzing person-environment interaction effects on activity and participation? Have you looked at any results from that type of analysis from your first wave? Seems like a great opportunity for examining moderation or mediation processes.
Yeah. So this is Carrie. That's a really good question. So we're just starting to look at the environment aspects of the survey. So we do have some information such as we use the chief survey. We have scores on where they live, the area deprivation index, and we know what resources that they were accessing in their environment. So we do have plans to take a good look at how they perceive their environment, what resources they're using, and how that does link to participation, but we are in the early stages of it.
Thank you, Carrie. Our next question is for Joy and Jacqueline. Great to see the spatial disparity maps. Was any evaluation done of the maps and analysis shown? Sometimes the analysis can be complex. Were you able to examine how well participants understood the maps and analysis, or the strengths and limitations of the analysis?
Mm-hmm. Yeah, that's a really good question, and something that we're spending a lot of time on in ADA Park is how to translate that information. So first of all, I'd say the maps are actually more accessible to certain populations, right? Certainly not as accessible to people who can't see them. But for people with cognitive disabilities, developmental disabilities, and I would say for some of our stakeholders as well, some of the policymakers, the visual maps showing a neighborhood and where people with disabilities are living and how economic status plays out in that and access to resources, they took and they used. Actually, it's just explaining through it, and kind of building a map with them so that they understand it and can do something with it. And part of it is when they have their own community in front of them where they recognize the neighborhoods, that helps immensely, right? That's why the community reports are so needed on that front. But for general accessibility, right, aside from that group, part of what we do is we always provide textual analysis and verbal analysis, of what it means. So just like I told you, 1/3 of the people are living within a lower SES neighborhood. It's the same thing, that we need to provide that information in lots of multiple and alternative formats to be able to do that. But I think the combination of them are very powerful, right? And the alternative formats, having multiple formats of it, is actually very useful to the communities. And we saw different people in different roles taking on different ways of looking at that information and then taking it into action.
Thank you, Joy. Our next question is for Lisa again. Oh, I'm going to see if I can get her to come back for us. Lisa, what are the next things which we need to study based on what we've learned about physicians from your study? Also, what policy interventions should be considered? Would mandatory cultural competency training in disabilities at medical schools or continuing medical education make a positive difference?
Those are a lot of great questions.
Yeah.
So I'm not sure that I can answer all of them in one fell swoop, but let me just say, we need to fix this. This is a big problem. You know, I think it's a great idea to focus on medical schools. And in fact, there are a number of medical schools around the country that are doing really great work with medical students actually leading the way. But that's a pipeline. And from the day that a medical student goes in the door till the day that they finish like a 3-year internship or residency is 7 years. And so we really don't have time to wait for the pipeline of new trainees. We need to get this out there right away. I think that that we need to look at continuing medical education and requirements in states for continuing medical education. States such as mine, Massachusetts, actually require certain types of continuing medical education for certain types of concerns. For example, CME credits are required to look at patient safety concerns. And so maybe we need to think about requiring physicians to make certain CME credits relating to equity. So not just equitable care for racial and ethnic minorities, which I think we need to focus on, but also equitable care for people with disability. And then also, I do think that we need to try to get the Department of Justice to do scoping reviews on the diagnostic, accessible medical diagnostic equipment. I didn't have time to talk about our findings from that, but pertinent to the second talk, we found that only 40% of physicians have accessible exam tables, and only 20% have accessible weight scales. And so if physicians don't have accessible equipment in their offices, the notion that they would think about providing accessible care to their patients, it just doesn't fit together. There's a disconnect there. So I think that there's a lot of work to do, but this really needs to be raised to a high level, and policy people really need to start thinking about this.
Thank you, Lisa. Our next question goes back to Vin and Monique. Seems to be from a fellow researcher. Here's the question. I would really be interested in knowing what recommendations you would have in using the deliberative dialogue and what advantages you saw. This person says, I'd love to use that method in their research.
So I could answer the question. This is Monique. So the advantages of doing the deliberative dialogue method is, one, to be able to have everyone's input into the discussion, have everyone to be able to identify, for example, in the case of our study, to be able to identify specific barriers or problems, and then to be able to come up with recommendations and solutions as a group, as a whole, in addition to really thinking about whenever they come up with a recommendation, to also think about the pros and cons. What are the circumstances that must be considered, as well as who should be involved if one was to carry out that recommendation. So I highly recommend it if comparing it to other kind of qualitative methods. This one is really about is great for really addressing, you know, issues that may be controversial, where there's a difference of opinions, you know, topics that are dear and near to a specific community or a group. So I would highly recommend I would highly recommend it in those types of scenarios.
Thank you, Monique. Our next question goes back to Kurt and Mel. What organizations provide quality training for healthcare providers on improving the treatment of patients with disabilities and implicit bias?
Well, I can't start my video, so I'll just have the mute on, turn my mute off.
Hold on, Kurt.
I think I go back to what Lisa's just saying, is that continuing medical education is probably one of the big tricks. And I agree with her that getting that into state law or rules is critical. We recently had a project where we were training rural physicians, primarily neurologists, on how to on holistic treatment of people with multiple sclerosis. And it was really, people had a lot of resistance to participating in training just because they said they were so darn busy. And once they were involved, they appreciated it. But it's hard to get physicians involved in continuing education. They have an awful lot of discretion over what they sign up for. So I think getting it required by the licensing laws and state laws is the way to go. In regard to who will do it, that's an interesting question, because it has to be people who have credibility. And I think, yeah.
Thank you, Kurt. I believe that we might be on our last question. We'll see if we have time. This one is for Dr. Iazoni. Dr. Iazoni, it's a two-part question, I suppose, so bear with me. You may want me to remind you. We'll start with the first one, the first part of it, which is, were there any questions which tried to tease out differences in views depending on disability, sensory, neurological, psychological, etc.?
Yes, so our survey had 8 modules. And as I said, I was only presenting one of the modules to you today. We had separate modules relating to mobility, disability, hearing, vision, intellectual disability, and mental health.
Thank you. Our second part of the question, which is not related, so I suppose it's not a two-part question, but it's still for you anyway. Do any medical schools offer opportunities for medical students, or do any hospitals provide opportunities for healthcare professionals to interact with people with disabilities in a non-medical manner, which permits them to learn something about people with disabilities in a different context to allow greater perspective about their lives?
Yeah, I saw that question come in on the Q&A, and it was such a great question, because there is a thin thread of research, but it's there, that suggests that if physicians get to know people with disabilities, just hang out with them, spend more time with them, that they view their quality of life as better. And so I certainly know anecdotally of medical students kind of organizing their own kind of like, actually Harvard Medical School right now has a house calls type of program where the students kind of hang out on a day with a family, with a person with a disability. And so I think that there certainly are sporadic programs like that, but that certainly is the way to go, to just get physicians to know us, know about our lives, know that when we're not coming into the office, we're living our lives 24/7, 365. We figured it out, you know, and have them see how we do it.
Thank you, Dr. Iazoni. That does wrap up our questions. I will turn it back over to Kurt for just a brief statement, and then we'll go to our break.
Great, thank you. And I'll just mention, Lisa, that we were in South Africa a while ago, and one of the medical schools there actually requires all the medical students to spend a month with an independent living center. And it's a different kind of medical education, but it certainly did give people a different flavor of what the issues are. So I want to once again thank the presenters this morning. We really appreciate it. I think that you provided excellent overviews of your research. We're going to transition into a break. We'll have 15 minutes and we will return at 11:55, and Mary Lou Breslin will provide a overview and summary of what we've heard this morning and help us end this. So thank you all so much, and we'll see you in 15 minutes. Well, welcome back from our break. I'm pleased to welcome Mary Lou Breslin from the Disability Rights Education Defense Fund. I think many of you know her. She's been a stalwart of our community for many years and demonstrated a lot of leadership. She's going to reflect on what she's heard this morning. And with that, welcome, Mary Lou.
Thanks very much. So, hi, everybody. My name is Mary Lou Breslin. I'm an older white woman with short gray hair, and I'm wearing glasses and a black shirt. My pronouns are she, her. So I'm a disabled woman. I'm a longtime wheelchair user because I had polio as a kid. I'm a senior analyst with Disability Rights Education and Defense Fund, and we're a national law and policy organization with offices in the San Francisco and Washington areas. I'd really like to thank the conference organizers for inviting me to respond to these great research reports that everybody's been doing on so many diverse ADA-related topics. As Michelle Bishop said at the top of this program, it's really been quite a year. This is the year when I think we've all been even more thankful for having the ADA. For example, it's really been a critical tool in challenging the discriminatory crisis standards of care policies that several people have mentioned, and that a number of states adopted to guide healthcare services rationing during COVID. These devastating policies contributed to ending the life of Michael Hickson, who most of you probably will remember reading about in the newspaper. At age 46, Michael Hickson's death resulted from a hospital's refusal to provide him with life-saving COVID-19 care and withholding nutrition and hydration. The hospital wouldn't provide him with medical treatment because it deemed him to have a low quality of life due to his pre-existing quadriplegia and head injury. So we were very, very happy to have a tool, a legal tool, an advocacy tool to challenge the policies that led to Mr. Hickson's death. The ADA has also been a fundamental tool in challenging hospital visitation policies when family members and personal care assistants were barred from accompanying somebody who was being admitted. And administration of the COVID vaccination programs have been rolling out around the country. The ADA has also been really an effective tool to increase vaccination site accessibility and improve digital communications, particularly for people who have difficulty accessing websites. So even as the past year has laid bare extraordinary inequities, their very exposure has also presented some unique opportunities, as others have mentioned. Kurt Johnson mentioned that working at home has become a norm rather than the exception, which I think is exciting because not so long ago, people with disabilities were frequently told that we couldn't work at home, even though doing so might make it possible for some of us to be employed. Telehealth offers new opportunities, as has been mentioned, while also presenting possible new barriers that we have to keep an eye out for to receiving equitable healthcare services. COVID's also upended some entrenched practices, perhaps for the better. Increased federal funding for home and community-based services is the mechanism that enables meaningful implementation of the US Supreme Court ADA decision in Olmstead. And it's a direct outgrowth of both really high-level community advocacy and the awful, terrible circumstances that so many people faced during this really exceptional year. COVID also, I think, raised up the second-class status of the direct care workforce, and it contributed very significantly to the public's understanding of the complex synergy between people with disabilities and our personal care assistants, all for the better. As COVID vaccination allocation's been rolling out around the country, we've been seeing more challenges related to public health's understanding of disabled people with multiple health conditions who actually until quite recently, within the last few weeks, were not ranked in the top priority tiers to receive the vaccinations. I was really happy to see yesterday that HHS OCR released guidance that reinforces the role of Section 504 and Section 1557 of the Affordable Care Act in prohibiting disability discrimination in vaccination programs. Of course, the ADA, 504, 1557 contain really fundamental non-discrimination provisions that have been such important tools this past year. The vaccination prioritization process in many places raised powerful equity questions about the availability of vaccines in communities that experience high levels of healthcare disparities and are made up significantly of people of color. It was only after advocates around the country vociferously argued that these communities also include people with disabilities who are at high risk of either COVID infection or death, where these policies changed to include them in the higher priority tiers. ADA issues popped up also in a variety of unsurprising and surprising ways as the allocation policies turned into practices. People were reporting having difficulty signing onto websites to make appointments for the vaccine. Others faced access failures at vaccination sites, and still others who don't use the internet couldn't access basic information about availability, or they lacked other communication accommodations. Blind advocates have raised serious concerns about website accessibility for making vaccine appointments and access to basic communications such as stakeholder and public meetings where internet platforms are inaccessible. So these advocates, though, were able to use the ADA as a lever to address some of these issues in some locales, sort of reaffirming how important this really powerful legal tool is. So interestingly, in California, a data tool called Healthy Places Index has been used to identify priority neighborhoods hardest hit by COVID, and then those neighborhoods have been targeted as vaccination priority areas. So again, unsurprisingly, the Healthy Places Index, which included some disability data as a health outcome measure in an earlier iteration, now excludes disability as a direct indicator. Instead, disability has been moved to what the authors refer to as a decision support indicator. I have to refer to the data analysts and quants in the room to fully explain the reasoning for this. But this actually really raises questions about how we want to tackle including disability indicators in a useful way, not only in this very highly sophisticated tool, but others like it. It raises the question of how to factor in environmental barriers to community participation from our viewpoint as a disability community. For example, the index includes domain indicators for major issues like transportation and housing, and yet we're challenged to find ways for this tool to accurately reflect health disparity causes that relate to people with disabilities. So can the Community Health Inclusion Index have a role? Probably. The research findings reported by Joy Hamill and colleagues on disparities presented in community action reports on community living and community participation also point to an important path forward on collection of data that not only can facilitate advocacy, but can also augment tools like this Healthy Places Index, so people with disabilities aren't ignored or worse yet, forgotten in times of community crisis. It seems to me that what's important in this conversation is that researchers are, all of you and others are focusing on understanding how the complex factors that contribute to the fabric of community are deeply interconnected, and policy levers can be used to address some barriers. I think the challenge for all of us ahead is to increase the use of these tools and to integrate the data they collect with other sort of widely used algorithms, such as California's Healthy Places Index. It's really great to see the work that Joy Hamill and others have been doing to really open up this conversation and contribute to it. So against this challenging backdrop, we have the research outcomes that Lisa Iazoni presented on physician attitudes toward people with disabilities, and that Kurt and Mel presented on the significant barriers that we all are still experiencing accessing healthcare. I have to say that for those of us who have disabilities, these findings only reinforce and support, thankfully, with data, what we have known for a long time. Certainly one of the most stark findings from Lisa's work is that 82% of physicians responding to a survey indicated that they think people with disabilities have an overall worse quality of life than others. I know she said it 2 or 3 times, and this is probably the 4th time we're saying it in this program today, but the fact that we now have this data to support the experiences of many of us is crucial, I think, for any next steps that we take as a community to try to tackle these intransigent problems. It's also important that we think about how to act on the fact that women physicians and safety net physicians are less likely than men or non-safety net physicians to report a worse quality of life for people with disabilities. I found that finding really fascinating. It just seems to me there are lessons in these findings about where ableism is most deeply rooted and what we need to do to reverse it. I think we know that if you have a disability or you have a family member, a friend with a disability, as we talked about before the break, chances are greater you're going to appreciate and understand what living with disability is like because of that personal perspective. I think the physicians that are working in the safety net programs are likely to have contact with significantly more people with disabilities than doctors in private practices. And that degree of exposure and contact with disabled patients is likely to influence their attitudes and assumptions about the lives we lead. So I've done some work with our federally qualified health centers in the San Francisco area, and who do serve a high number of people with disabilities. And we learn from focus groups that they generally do their best to try to accommodate disabled patients if they can, though practically speaking, they have limited capacity. Many actually don't have accessible exam tables or weight scales. They have very limited knowledge in advance about the needs of an individual patient coming into the clinic or on any given day. Our focus groups revealed that while a few of the clinic staff have heard of the ADA, we sort of asked them to give us a show of hands and tell us what they thought the law was. They really don't have any idea what it is, what it means, what it does, how it works, how it applies to them. And interestingly, though, after hearing more about the ADA during the focus group discussions, they said they were really excited to learn more and asked to be have an opportunity to hear more. So I even though it's difficult to find ways to engage in this kind of educational process, I think there's a lot of willingness to listen and learn if we can find the pathway into providing this kind of training and overview of the ADA. So the healthcare research that we heard about today sort of reinforces the message that we need to be seen, we need to be participating everywhere. People are being educated to become doctors, dentists, nurses, and others in the allied health professions. And we need to be students in those programs, and we need to be practicing medical professionals, and we need to teach in those programs and participate in all kinds of research, not only as subjects, but as researchers. So it's really high time that the research community, and that's really pretty much all of us here today, take responsibility for embracing principles of disability justice by kind of centering disabled members of marginalized communities in research work as researchers, as mentors, as mentees, as practitioners and spokespeople whose voices are at the table. And we have to change the discussion about the ADA. From my perspective, the law provides a really great template for how to provide culturally competent care, yet most medical professionals think of it as having to do with blue handicap parking places or bigger stalls in the bathroom. And it doesn't really have anything to do with their work as clinicians. Perhaps they even perceive it simply as being a burden. The challenges still ahead include convincing medical professionals that something as common as a height adjustable examination table or an ASL interpreter or an extended visit to ensure effective communication are some of the factors that contribute to and define healthcare equity for many people with disabilities. And the research that we heard about today gets us closer to this goal and makes the case for teaching disability competency and requiring it for licensure and certification and in continuing education courses, as Lisa mentioned. California, incidentally, is requiring implicit bias training and continuing ed and are moving toward including disability in the implementing standards for the new continuing education rule. I think this holds out hope for us in other states as well. So Kurt Johnson and Mel Toy's work also reinforces what many of us know from a lot of experience. There's a crucial lack of accessible medical diagnostic equipment in clinician offices. Even though the ADA has been in force and effect for over 3 decades, Kurt and Mel's work reminds us that physician offices and clinics still have architectural barriers, lack interpreters, and often have policies that create barriers for people with mental health disabilities. These findings are supported by work I've done with Professor Nancy Mudrick with the School of Social Work at Syracuse University. We looked at accessibility ratings of nearly 4,000 medical primary care physician offices in California that had been evaluated using an 84-item survey instrument. And I think one of the most interesting findings that came out of that work was related to the availability of accessible medical diagnostic equipment. So 19% of 4,000 Medicaid primary care physician offices had height adjustable examination tables, and under 11% had wheelchair accessible weight scales. I'm really thrilled to hear from Lisa Iazoni that her more recent study shows that those numbers are actually much higher among the physicians that she surveyed. Perhaps we're actually making some progress. We also found a fairly high level of physical accessibility in the offices whose data we reviewed, not taking into account whether trash cans blocked the bathroom doors. But bathroom elements themselves presented actually the most frequent accessibility problems. Well, just as an aside, a colleague recently told me that her husband, who's a person of small stature, was told by his physician, who practiced at a large medical center, that no height adjustable examination table was available because it wasn't cost effective. Of course, if you have a disability or you know somebody who does, and you need this equipment, chances are you've had the same experience. You know, the stories are just ubiquitous and have been for decades. They don't change from one year to the next. My own favorite story actually has to do with my own healthcare provider, which is a large system operating in Northern California. In fact, they have accessible weight scales, and that's the result of many, many years of ADA litigation. But it happens to be mounted in an alcove, and the ramps on either end are blocked by walls. This particular scale is bolted to the wall, even though it's intended to be portable and otherwise could be moved from one location to another. It's a good thing I figured out how to weigh on the laundry scale. So we are really most certainly challenged to understand why it's been so difficult to persuade healthcare providers to embrace the idea of accessibility and accommodation. Kurt and Mel's findings report all the things that we know so very well. Lisa suggests a number of causes of health disparities among people with disabilities, and among them are notable ADA fails, including ineffective communication accommodation, lack of accessible diagnostic, medical and diagnostic equipment, and inadequate knowledge about ADA mandates. She also mentions ableism attitudes and erroneous assumptions about people with disabilities. So one practical solution for at least one of these concerns, as we were talking about earlier before the break, that would, I think, make the ADA a more effective and valuable tool, and this has been mentioned by others, would be for the Justice Department to issue scoping regulations that lay out how many pieces of accessible diagnostic equipment that meets the Access Board's accessibility standards are required in medical facilities of various sizes and purposes. Similarly, the Department of Health and Human Services could regulate this requirement, and it is my hope that in the future they will consider doing so. If medical providers were legally required to have accessible medical diagnostic equipment, then perhaps doctors and other medical practitioners would come along with less resistance. As it stands now, individual disabled people are pretty much on their own in making the case, either through personal advocacy or by filing a complaint. I was really happy to see that Kurt and Mel's report on lack of functional limitation information and accommodation needs in electronic health records. It's always seems like a no-brainer to me to include the American Community Survey disability questions in electronic health records, even though we know they're not perfect questions. If somebody says they have a communication limitation, a drop-down menu should appear asking what accommodation they need for the upcoming visit, and that accommodation should be flagged for the appointment. As we know, though, this has been quite a hard sell. I've been really happy to hear recently from colleagues that the models for including this data are developing at several universities, and that several health systems are also collecting it. So research that I carried out with Nancy Mudrick at Syracuse with the federally qualified health centers here in the Bay Area showed that if you ask these questions upon a patient registering for care, about 9% will identify as having a functional limitation that might require accommodation during an office visit. How great would it be to have this information easily and readily available when people make appointments for a medical visit? I suspect this issue won't turn the corner, though, until health information technology such as Epic and other electronic health record systems observe that clients want this information, or that it's federally required by HHS or even the Office of the National Coordinator on Health Information Technology. Lisa and I had a recent conversation about this, and she's not optimistic that this is possible, but let's throw it out for consideration again. I was really struck by Michelle Putnam and Carrie Morgan's findings that people aging with disabilities responding to their survey said that the things that would change their life the most would be more personal assistance, environmental modifications, improved health, and assistive technology. These reflect the practical needs of disabled people who are aging, but also their life experience, which values and understands how life-changing certain technologies can be. Unfortunately, many health insurance policies and Medicare policies don't support the needs of older people with disabilities for assistive technology, environmental modifications, and even personal assistance. Take, for example, Medicare's use of the in-home policy, which requires that in order to be eligible for a mobility device such as a wheelchair, the person must require the device for use in the home for medically necessary reasons. No consideration is given to whether or not the device is needed so the individual can travel around the community. This old and outdated policy sometimes has the effect that an individual with a significant disability isn't eligible for a wheelchair they need because it can be difficult to make the medically necessary case for certain independence enabling features such as seat elevators. Curiously, though, companies involved in developing autonomous vehicles are concerned about this restrictive provision because they're worrying that Medicare beneficiaries won't be eligible for wheelchairs that have lockdown devices that are compatible with autonomous vehicles because those devices aren't needed for use in the home. This creates a barrier to achieving ADA accessibility from their perspective. On the private front, private health insurance, it includes many policies that have capped the amount of money they'll pay for devices such as wheelchairs and scooters. So in some situations, there's annual caps on the benefits. For example, $1,000 or $2,000 is the annual limit. Doesn't really make much of a dent if you're buying a $25,000 wheelchair. And of course, private health insurance doesn't pay for personal care services. So these policy barriers prevent people who are aging with disabilities who have acquired disabilities as they age from getting the personal assistance services and technology they need to continue to live independently. These examples illustrate the limits of civil rights law. We need other policy levers to solve some of these problems. So one bright spot is that the administration is championing funding for Medicaid home and community-based services. This is a growing recognition that we have to find ways to meet the personal care needs of an aging generation, as well as younger people who have extensive disabilities and require support to live independently, but are often on long waiting lists. This hard-won policy shift circles back around to the impact of the independent living movement, the disability rights movement, the deinstitutionalization movement's influence on the ADA's integration mandate, and the outcome of the Olmstead decision. Financing trends tell us that more Medicaid funds are now being spent for home and community-based services than for institutionalization. Even though Medicaid community-based services, including personal care services, are not in and of themselves a requirement of the ADA, they're an essential tool that gives life and meaning to community integration. Similarly, states such as Washington have enacted social insurance statutes that working people can pay into and draw down later if they require personal care services. California is exploring the same possibility. So my biggest worry, I believe, at this point is that, and based on the healthcare research we're hearing today, is owed to the fact that the public health community hasn't embraced disability as a bona fide health disparity demographic population. The COVID epidemic has shown that we simply aren't a part of the health equity framework as it's currently understood, and that's so frequently touted. Selling the idea that we should be has been a daunting challenge. I hope some of you who are listening today have had a different experience, but I think as we look ahead, we have a lot of work yet to do to change this paradigm. I just want to circle back for a minute to my earlier remarks about the use of the Healthy Places Index in California to identify communities hardest hit by COVID. Advocates worked hard to help public health officials understand that marginalized communities of color were targeting for COVID vaccinations also included significant numbers of people of color who had disabilities. Unfortunately, it was a difficult lift to convince officials to even use available disability data for these communities to help make policy decisions about how best to distribute the vaccination. This stark omission made it more difficult for people with certain disabilities living in these areas to obtain vaccinations. Slowly, though, advocates made headway, arguing for augmented transportation, home visits, and certain accommodations people need to safely get a vaccine. But these successes were not a function of public health systems or algorithmic tools, fully including disability in decision-making, or of public health personnel's awareness of the ADA for that matter. They were owed more to our fundamental belief in the power of advocacy and disability rights principles. While I'm using the COVID experience as an example, we're seeing other potential problems arising from this widespread omission of disability by public health. For example, hospitals are using algorithms to make certain treatment decisions, but we know these algorithms are starkly racially biased, and it's quite likely that many of them have no disability elements included in the data used to create them. Whether or not this is an ADA violation remains to be seen, but we do know that cases have been brought because algorithms have made incorrect decisions about benefits eligibility. Inevitably, they're also likely making the same poor recommendations in clinical care settings. This is both obviously an opportunity and a challenge for the future. Having said all of that, I really thank the researchers for their important work and their contribution to these evolving conversations. Policymakers can't do their work without you. Thank you so much for the opportunity to reflect on the work presented here today.
Thank you so much, Mary Lou. Your wisdom is always appreciated, and I think that you've offered us some challenges. That brings us to the conclusion of our State of the Science Conference. We deeply appreciate your participation. This was a great opportunity for all of us to review current research related to the ADA. And I want to remind you that you can continue these discussions or follow our work on our Facebook, Twitter, and LinkedIn pages. And don't forget to subscribe to our newsletter. On behalf of the staff here at the ADA Center, our ADA KT Center, it's been a real pleasure to be able to host this. When you leave, remember a Zoom webinar, when you leave the Zoom webinar, a window will open that allows you to do a survey with respect to today's conference, and we really appreciate your feedback. So on all of that, it's a beautiful day here in Seattle. I hope it is where you are. And thank you again so much for coming.